I'm not going to call anyone out, but I'm going to say that there are a number of people I wrote to via email as I started developing this data, but almost nobody was answering my calls. Let me put it that way.
So Bill, why answer those calls?
Well, it was novel. The usual when we think about lipids and lipoproteins is on the order of months. Now, here's Dave who comes along with his N of 1 experiment and says, in a matter of days, I can radically change my cholesterol. We've not talked about that in lipidology.
Because we'll be able to also see if there's a correlation between LDL levels, especially apoB, and both incidence and progression of plaque.
So the soft pushback I would have on that is that
in today's episode, I sit down with Dr. William Cromwell, or Bill, and Dave Feldman to discuss how blood lipids affect our risk of cardiovascular disease. Dr. Cromwell is a lipidologist with over 35 years of experience. Dave Feldman is a software engineer and citizen scientist who, after adopting a ketogenic diet, noticed that despite markers of metabolic health improving, his LDL cholesterol elevated severely. His question since then has been whether or not high LDL cholesterol is a problem in the background of optimal metabolic health. I've wanted to have this conversation with Dave for some time to better understand his views. We've had private back and forths for, I believe, 6 to 7 years at this point. Given lipidology is not my specialty, I invited Dr. Cromwell on for a balanced discussion. It's a pretty nerdy deep dive into lipids and atherosclerosis, the buildup of plaque in our arteries, not for the faint-hearted. But if you do love this topic, like me, then I think you'll find it incredibly interesting. Please enjoy. Bill, Dave, thanks for doing this.
Our pleasure, thanks.
Really interested to hear perspectives from both of you today on a number of things, lipid and heart disease related. To kind of kick things off and get people up to speed, let's just quickly go over kind of where both of you fit in here. So Bill, you're a lipidologist.
That's right.
What is a lipidologist and how have you kind of spent your career so far?
So lipidology is the science of cholesterol metabolism, essentially. It's a little bit more than that. It has to do with the particles that carry cholesterol and triglyceride and their relationship to things like heart disease, other diseases like the pancreatitis. So my journey in this area, if you want to call it that, started in the late 80s. I was one of the first guys to have a private practice lipid clinic in 1988, right? So at a point when nobody cared, and nor should they really at that time, because at that time we really did not have our understanding of heart disease, lipids. We didn't have very many therapies to even consider whether they would be reasonable or not. We had a lot of epidemiology. We had a lot of genetic understanding, some experiments of nature. But what was very clear to me was that we didn't have a lot of practical ways to move forward to blunt the scourge of heart disease. And it seemed that lipoproteins and cholesterol metabolism was part of that. So for the past 35 years, I've worn many hats. The clinical hat is I've had some form of a lipid practice since then. I've been head of a variety of divisions of atherosclerosis and lipoprotein disorders. Spent 20 plus years in bench research using NMR as an analytic platform to quantify lipoproteins. Jim Otvos, who originated that technology, has been my research partner for 30 plus years. And then human research at various times in clinical trials. So between clinical trials, bench research, and clinical practice, that's where I've spent my 3 decades.
So we're in pretty good hands here. Well, I did speak to Thomas Dayspring before organizing this, and he couldn't do it, but he said, Bill's your guy. So I feel like we're in good hands if he's saying that.
Well, I appreciate his endorsement.
Over the 35 years in your clinical practice and even in your kind of research and just thinking about atherosclerosis, have there been many things that you've kind of changed your mind on?
Oh, absolutely. So this is a model, really. This is a disease model. And like any model, it's just a matter of, what's the new learning that informs the model. How do we modify the model in a way that I hope embraces all good outcome and findings? So one of the things I think we have to at least explore during this conversation is the interface between the particles that carry cholesterol and how they contribute to vascular disease, and cholesterol as a biomarker of those particles. And that's really what the story is. The story is not that cholesterol causes heart disease. The story is not that there's good or bad cholesterol. The story is that there are particles that carry cholesterol that can have punitive or protective characteristics.
Right. And here, in terms of being potentially problematic, we're talking about apoB containing lipoproteins, just to kind of, there's some overlap here with previous conversations that I've had with Thomas Dayspring.
Right. So the apoB pool is a group of particles, 90% of which are LDL. About 10% are other things. And there are various reasons why apoB particles have the potential to be atherogenic.
Okay. So we'll come back to that.
Right.
Dave, you're a software engineer and a citizen scientist. What is a citizen scientist, I guess? Is that something that you even refer to yourself as, or is that something that other people refer to you as?
Yeah, it's fascinating because I would argue that my life was entirely about software engineering, really up until about 8 years ago, 9 years ago, 8.5 years ago. So basically November of 2015 was when my life changed. After 7 months of being on a ketogenic diet, I got an 8.5 sheet of paper, 8.5 by 11 sheet of paper that changed my life forever because my cholesterol levels had gone through the roof. I found that to be surprising because my other first degree relatives who also started keto around the same time did not see their cholesterol levels rise substantially. And so I became obsessed with trying to find out why. And so, as you probably heard, I started doing a lot of self-experiments, N of ones, to eventually elucidate that actually my lipid levels changed quite rapidly depending on what I was eating in this ketogenic context. And what I liked was, coming from software engineering, I work with networks all the time, distributed objects that are interacting with each other. And that's actually what the lipid system is. And so then I got a lot more interested, kept doing more experiments, eventually started blogging about it, giving presentations on it, and then connecting with a number of different people at higher and higher levels. Eventually, got to the 10th level boss over here.
So you guys, I mean, we spoke off air, but you have met before and done podcasts and spent time with each other.
Right.
Yeah. It's fascinating because we were just chatting about this. He was really the first lipidologist who not only was able to get some time chatting with, but was good enough to provide, an ear to soundboard off of. And
what was your initial motivation to adopt the ketogenic diet?
Actually, to avoid type 2 diabetes, which is rampant in my family.
Did you have pre-diabetes?
Yeah. I had an A1C of 6.1 2 years in a row. And so it coming the second time in 2015, I was pretty adamant about trying to figure out a way to not get it. Mm-hmm. And at that time, it wasn't really keto. It was LCHF, low carb, high fat. Right. But I found that the forums were chatting about it a lot. And I remember distinctly at that time writing, well, wait a sec, if I'm having a lot of cholesterol and saturated fat, aren't I going to get a high LDL cholesterol? And they said, no, that's actually pretty rare. Mm. Almost nobody gets a high cholesterol after going on a ketogenic diet. And that was the starting point.
So you meet Bill. Bill's, I guess I kind of sort of just interrupted them, but I think you were alluding to the fact he was, for lack of a better word, one of the first lipidologists to kind of take you seriously or be interested in what you're doing?
I think so. I mean, I'm not going to call anyone out, but I'm going to say that there are a number of people I wrote to via email as I started developing not only this data, but what I felt were the early beginnings of what we may be chatting about, the Lipid Energy Model, that I felt, was fairly straightforward in how it explains why these lipid levels change as rapidly as they do, and could also have further relevance with regard to being on a ketogenic diet. But almost nobody was answering my calls, let me put it that way.
So Bill, why answer those calls? There's a number of people, and again, I'm not going to name names, who I think just take the position that we understand what's causing atherosclerosis, why entertain any of these ideas, why have these conversations? Is it productive? Is it useful? Is it clarifying?
Well, it was novel. So the usual way we think about lipids and lipoproteins is on the order of months. We see people say every 3 months if we're doing something to improve their values. We'll see them every 6 to 12 months if they're well controlled and we're just keeping a finger on the pulse. Now, here's Dave who comes along with his N of 1 experiment and says, in a matter of days, I can radically change my cholesterol. We've not talked about that in lipidology. We don't have models where we're looking at people on a daily, weekly basis to see, well, how quickly can we modify what are reasonably steady state levels for most people. So just the fact that this was reproducible and the fact that as he was going through this very methodically, if I do this, I get this. If I go back to this, I get that. And let me tweak the system again. So he had a very organized series of data, which were very interesting because in that time frame, I would not have thought that values would have shifted that much in that shorter period of time. And B, the fact that he was able to begin to dial in a set of variables that he could almost call the ball. You know, if I do this, I bet my levels will go to about this level. And pretty close, right? So there's something to learn here. We don't usually think of that in lipidology. And B, the mechanisms that might drive that aren't your usual mechanisms that we have in the textbooks. So part of it was interest and what can I learn from this? And then secondly, the question of what impact does this have as far as risk is concerned? Because our model for risk for almost any risk factor is how bad for how long. Mm-hmm. Bad things for a long time, increased risk. So what would be the downside of having a super high LDL for a week, 2 weeks, 2 months, 2 years? How long does it have to be high to really drive things in the wrong direction? Does it happen on day one? Probably not. You can think of smoking, for example. Somebody who's smoking, we think of pack years. How many pack years have you been smoking? If you just picked up a pack of cigarettes today, you don't have the same risk as somebody who's been smoking for 20 years. So this begins to bleed over into other thought processes of how do we ascribe risk to individuals? What's the big picture? And if somebody's looking at me and saying, well, should I be concerned? How concerned should I be? Do I have to take a drug? Can I just modify my diet or lifestyle if that's what was responsible for a lot of this in the first place? So there were a lot of practical edges to this that I could see would be helpful to understand.
Right. So just clarify something for me and the listeners, so kind of bring everyone up to speed with exactly what we're talking about here. Dave, you're talking about you adopted a ketogenic diet, which is it's high fat, it's low in carbohydrates. You got your blood work done. You saw extremely elevated LDL cholesterol. What level was that at?
Historically, my total cholesterol was around 180. My LDL historically was around 120 to 130, which is right about the midpoint for a male my age. When I adopted the ketogenic diet, I believe my total had gone up to something like 340 or 350. My LDL to something like 240, 250, something.
Right. And at the same time, your HDL was relatively high and triglycerides relatively low, I'm presuming.
Correct. Both of those moved in that direction.
Right. Okay. And was that like a new sort of cluster of lipids that you hadn't seen before? I guess where I'm getting at is why look at that and think, wow, that's interesting, when, you know, I know that there's other lipidologists who I guess just look at that and say, well, his LDL is elevated. That's not optimal. It can't be optimal.
So a couple of thoughts. I don't believe that people have high LDL for a long time with impunity. So I think you will eventually have a consequential bridge to cross in most cases. The higher, the longer, the worse. Now, for the reasons that things are going up in lipidology, we think of production and clearance. Whatever I have a lot of, I made a lot, I didn't get rid of it, or both. So if Dave is making a diet modification, his LDL almost doubles. Is that a production problem? Is that a clearance problem? Is that a combination of the two? And when you think through those pathways, and it's happening in a matter of days, that challenges some of our thinking as to why LDL is historically high in people, for example, with a genetic problem where they can't clear their LDL. Now, clearance doesn't change that quickly in that shorter period of time necessarily. So just the time frame of these fairly significant changes in a short period of time, and then me as a lipidologist thinking production, clearance, both, what's going on here?
Right. So your question is, are those apoB containing lipoproteins behaving similarly within that context to other contexts?
Well, two questions. Why they're high, what mechanism is driving them, and then we really go back to the model that we most commonly see people in an unfavorable lipoprotein state chronically, and their chronically abnormal lipoproteins are contributory to their vascular risk. Have we seen series where people were otherwise fine for the majority of their life, and then a switch was thrown, and now we have LDLs in a level that would historically be very worrisome? Does it stay there? Is that their new normal? If it's that new normal, then we have a different conversation. Well, what happens after 3, 4, 5, 10 years of this, right? Maybe this is transient. Maybe what we're catching is the body adapting to some sort of major macromolecule change, and it's going to peak and it's going to come down. And in some people it does.
Are you saying so it peaks and then it comes down back to a new kind of baseline over weeks or months, or are you talking about throughout the day it's going up and coming back down?
So this was the interest, right? So Dave was the first person that could show me data where we could begin to ask those types of questions. And so early on, why would I take an interest? Because this type of time frame of change I hadn't seen before. And there are a lot of questions of, well, how long does it take? And how steady state is it once it gets there? Are there people, for example, who are reasonably compliant with the same diet over time, and the numbers go up to a new level and stay there? In some cases, for various reasons, do they attenuate and begin to come back down? These were all things I was interested in trying to understand.
Has your LDL cholesterol remained at that level? I'm assuming that you've continued to sort of adopt this ketogenic diet.
Yeah, it has, which also conforms to the model, to the Lipid Energy Model, per my expectation. When I was coming into this space, people did speculate that if you saw your LDL increase, it was probably going to come back down again. And to be fair, there is some context around that that's worth appreciating, which is that indeed, if you're actively losing fat mass, you are liberating more of the lipids that are inside your adipose tissue. And if that's happening, then sure, there actually is a clear physiological reason for which you might have higher VLDL being produced by the liver and thus higher LDL. But once weight's stable, would you still see your LDL being higher? And I would contend that generally speaking, if you're metabolically healthy and generally leaner, it's more likely than not that not only will your LDL be higher, but even at weight stability, it's probably going to remain persistently higher, especially the leaner you are.
This is more of a personal question. And I'm kind of asking you to speculate a little bit, but why is it that you think some other lipidologists are not open to having these conversations with you?
You know, I've had this conversation with Bill literally just in the last hour. We were chatting on our way here. I really mean this when I say it. I genuinely think that a lot of the lipid hypothesis not only is heavily entrenched, but there is a sense that obstruction of that, even as well-intentioned as you may want to cast it, can still be seen as harmful for their patient care. So I think a lot of people who are detractors to my research are actually genuinely well-intentioned. But to an extent, it's true. A number of them have difficulty having this conversation because they're concerned it's platforming a kind of, as is often referred to, a kind of denialist position or something along those lines. All I can do is the best that I can to continue to try to engage as reasonably and as cordially as I can.
Okay, so I want to put a pin in the lipid hypothesis, come back to that and clarify what your view is, I guess, on whether you agree with some of it, part of it, whether you think it's totally wrong, whether you think it just doesn't apply in certain contexts, etc. So we will come back to that. I just came off a 7-day diving trip in Socorro. Told you about my customs issues last night. And do either of you scuba dive?
I don't.
No, okay. So neither had I until a few months ago. I did my certification, and I think I had 5 dives before I went, and I was going there with this super experienced group of divers. Socorro is 600 kilometers off the west coast of Mexico, Cabo, and it's a spot where you can see manta rays and hammerheads and dolphins and incredible wildlife, but crazy currents and very advanced. And so I was lucky that the advanced divers I had really, like, we went down quite slowly. And I'm thinking about this because I think that was helpful for me. I had a great experience, and here we are sitting here, and you guys are completely very experienced with lipids. I want to make sure we don't just get straight down to the bottom. So let's try and hold everyone's hand like they held my hand and got me down without my eardrums bursting. And I had a lot of fun, and hopefully the listeners get the same out of this conversation. So if we kind of just descend slowly here, Bill, what is the kind of current model or lipid hypothesis as it stands today?
Well, I take you back. So the history of how we got here, I think, is important to answer that question. So the history of how we got here was, it was not lost on people that cholesterol was in plaques back in the late 1800s, early 1900s. Now, how it got there was a mystery. Was it made? Was it transported? It didn't appear to be made, so it had to be transported. And now you have to ask more questions. How do you move cholesterol, which is a fat, in blood, which is mostly water? And people thought, well, maybe it hitches a ride with albumin or a plasma protein, that sort of thing. But the real work here came from two guys, Goffman and Lindgren, in the 1948 to 52 time span. And they characterized human lipoproteins. They're the guys who figured out that we have these particles. They look like tennis balls. They're hollow on the inside. And inside, which is a fat safe place, the cholesterol and triglyceride get packed in the middle. And these particles are the way that we move cholesterol around. And so that was the beginning of what some people call the cholesterol hypothesis. It was really, how did cholesterol get into plaque? And then what do we learn about the particles that carry cholesterol? So in my world, I'm a little careful in the way that I discuss this, because I don't think it is a lipid hypothesis. I think it is a lipoprotein conversation. Lipoproteins are the core of this conversation. And this was actually what they thought would be the conversation beginning in the 50s. But it's hard to measure lipoproteins, especially back then. But you can measure cholesterol much more easily. So what you can measure easily becomes a surrogate for the rest of the story. Interestingly, some pioneers that were giants of the day in the 60s at NIH, Friedrichsen, Levy, and Lees, talked about the facts that, and they lamented this. They said it's unfortunate that people are talking about lipoproteins as a cholesterol problem. Really, that's not the case.
Cholesterol is just kind of getting caught up in this.
Cholesterol is a neutral fat that's stuck inside a particle. The cholesterol in HDL is the same as the cholesterol in LDL. Right, one is not good, one is not bad. One does not protect you, one does not hurt you. It's the particles that have the potential for good or for bad. And so what we think the model is today is, if you have any number of problems or processes that give you lots of apoB containing lipoproteins, and that stays high for a long period of time, that is part of the process that fuels formation of plaque in the artery wall that can grow over time and under various circumstances lead to heart attacks and strokes.
Is that independent of other factors? You know, one of the things that I was speaking to Tom Dayspring about when he was on my show was whether those lipoproteins, I think you said there, they have the potential to be good or bad. Are they inherently problematic, or is a particular environment or concentration required?
Yes and yes. So apoB containing lipoproteins, specifically LDL and remnants, are very atherogenic. There are lots of models where we can show that persistently high levels of these are directly related to development of plaque, independent of anything else. But like anything else in the body, multiple contributors together have a different impact than just one. So if you're a smoker, hypertensive, diabetic, if there are other things going on that also set the table for atherosclerotic risk, and you add a high apoB to that, that's a very different environment than just high apoB.
Right.
So yes, you can amplify the deleterious effects of apoB by other things, but it is not true that you have to have other things for apoB to be deleterious.
Okay, so you can be otherwise completely healthy, but have an elevated apoB above some physiologic level. And at that point, those lipoproteins will be problematic.
So this is a concentration conversation. The higher, the longer, the worse. So there's not a step function or a threshold above which people are in dire straits, but it is a continuum of risk. And as you escalate the number of particles to extremely high levels, and you leave them there for an extremely long period of time, that would be one working example where you can say, yes, under those circumstances, absent some other thing we don't understand, such as favorable genetics or other factors, this is a setup for plaque formation and increased atherosclerotic risk.
So do you think that applies, and we'll unpack the triad, the lean mass hyperresponder, but do you think that applies in this context of what's, Dave's experience himself, where otherwise, metabolically healthy, I'm assuming, triglycerides, high HDL, perfect, but his LDL is high above that physiologic level?
I think it's a great question. And you just teed up a different conversation. And that is that we're not a system that has only one thing going on at a time. So high apoB usually exists in the context of other things. In this culture, high apoB is usually part and parcel of insulin resistance, part and parcel of metabolic syndrome, part and parcel of prediabetes, diabetes. And so we have these other physiologic perturbances that are part of the fabric of atherosclerosis in which apoB is layered. And so that's the most common expression of high apoB-related risk that we have. Another example is familial hypercholesterolemia or other genetic disorders where you just can't clear your particles well. You don't have these other processes necessarily, but you do unfortunately have a lifelong exposure to very high LDL, very high apoB, and there's a consequence to that. So we have these two different models, one which is physiologically unhealthy, the other which is genetically driven. And in both cases, high apoB is contributory to atherosclerosis. But the magnitude and how much risk the individual has is more than just their apoB level. It is a combination of all these other factors. And so one of the challenges clinically, when I see somebody, if you were my patient, I would seek to understand, Simon, what's the rest of your story? Are you insulin sensitive? Are you insulin resistant? Are you a smoker? Are you hypertensive? Are you diabetic? What other comorbid conditions do you have? What other things are important? And the guidelines are now beginning to reflect this as well. The guidelines has a whole list of things called risk-enhancing factors that you're supposed to ask about that contribute to potentially what your risk would be. And then we layer on top of that things like apoB, Lp(a), lipoproteins that are atherogenic.
Right. And so you would find out all of that information because it may affect how aggressive you are or proactive you are with lowering my LDL cholesterol or apoB, or how worried you would be.
Yeah, I think the question you would have is, if my apoB is a bad number, what's the rest of the story? Now, we live in an age where we can do non-invasive imaging, and we can get an answer as to, using certain modalities, do we see evidence of plaque already? If I see that you have plaque and you want to talk to me about your apoB, that's a different conversation than somebody who is apparently physiologically healthy, has no evidence of plaque, has a high apoB. And my question is, has it been that way for a long time? Is that a more recent phenomenon? These are important considerations. And we can kind of unpack this as we go, but there are combinations and permutations of this where in one extreme, let's say you're 75 years old with a 0 calcium score and a high LDL. The guidelines would say statins are optional for those people. At a younger age, you tell me that you have plaque and you have a high apoB or LDL, I'm going to tell you that getting that down is the best solution at a lipoprotein level you have to stopping the growth of plaque, regressing plaque, decreasing LDL-related risk. And the term I just used there, LDL-related risk, I think is a very important nuance because it acknowledges, on the one hand, there is risk attributable to bad or atherogenic lipoproteins, but it's only one of many actors in the story of atherosclerosis. We have lots of data where people's LDL has been really well managed, and yet they can go on to continue to have events. So we just want to paint a broader context, a broader picture that as important as it is, it's part of a bigger story.
I imagine some people might push back a little bit on that last part there, and they might say, well, Bill, you might still see events because you've intervened too late in life. And I know that there are certain people out there that, it seems to me at least, that there's this idea that the precautionary approach that, is apoB the kind of, is it the spark that sets off the flame? And if so, if you just get it down to a low level early in life, are you going to help that person kind of avoid it? We don't know 5 years, 10 years out what this person's metabolic health is going to look like. Why not just aggressively lower it and get it to a safe level?
I agree with that. So primordial prevention is don't let it happen in the first place. Now, we have experiments of nature. You can look at people who genetically have low LDL for a lifetime, and they have markedly reduced atherosclerotic risk, irrespective of whether they smoke or they're hypertensive or other things happen in their life. Because if you kind of mechanistically look at this, you could ask, well, what's the committed step of atherosclerosis? And the committed step is forming macrophage foam cells. Formation of macrophage foam cells is the committed step of atherosclerosis. And what's a foam cell? A foam cell is a macrophage that ate atherogenic lipoproteins. So once you have begun that process, you have turned on the switch. All right, so that's an important caveat.
And just to underline something there, that process can begin if apoB or LDL cholesterol is elevated without systemic inflammation,
Correct.
Without insulin resistance. It can sort of instigate that.
It can.
Dave, we're going to come to you. I'm going to bring you in. Diet enters this conversation because the foods we eat can affect lipids. What's the diet heart hypothesis?
Well, that probably is something that each of us would have a different opinion about. So,
Well, that's great. That's what we're here to do, right?
I've heard a lot of different explanations of what the diet hypothesis is. I assume that we're saying that there are diets that, for various reasons, can contribute to atherosclerotic risk as well. Is that where we're going with that?
I guess.
Did you mean the lipid hypothesis? Because diet heart hypothesis usually wraps in saturated fat.
Right. So we spoke about the fact that elevated apoB in the current model, the lipid hypothesis is, I guess, part of the explanation as to why people develop atherosclerosis. And where I'm getting at now is, why does diet end up getting brought into this conversation? And at least to my knowledge, a lot of that research, yes, focuses on the fact that saturated fats raise these apoB containing lipoproteins relative to other types of fats.
Yeah. For me, it's funny. The diet heart hypothesis, the Ansel Keys version, as relates to saturated fat, can increase serum cholesterol levels. I feel like we're now at a point where we can kind of almost set that aside and be like, let's just focus on whether or not your LDL went up, whatever diet you're on. And if there's agreement that saturated fat can result in increased LDL, and that in turn results in greater risk for cardiovascular disease, it's almost like you can leave the diet heart as the older 40s, 50s model and just jump ahead to the lipid hypothesis from the lipid standpoint. Unless there's a hypothesis that saturated fat, absent raising LDL cholesterol, can increase your risk.
Yeah,
for
so you're saying the
cardiovascular
mediating
disease.
factor is the elevation in apoB.
I think that's what
LDL
all
cholesterol.
sides at this point are arguing about.
Right.
I mean, unless there's another version.
I might have got this wrong, and I might be misrepresenting your view, but are you of the view that the kind of underlying mechanism by which apoB is elevated matters, affects the degree to which these particles are atherogenic?
Before I unpack that, I want to emphasize something because this is kind of important. One thing I've become more sensitive to as my profile has grown is, unfortunately, people turning this into a false dichotomy. So I do have a distinction, a difference between where you and Bill lie. But it's more in that there's a greater confidence that apoB containing lipoproteins, absent all other factors, prove a causal directionality towards development of atherosclerosis. And I'm not arguing the reverse of that. And I want to put that up front first. What I'd like to do is lay out the case for why I don't think that we know enough. So there's a difference between I know it's atherosclerotic versus I know it's not atherosclerotic. I'm not arguing in this case. I do feel that we don't, I think, have enough data to suggest confidently that we know the true causal directionality of apoB containing lipoproteins absent these clusters of everything else. And I can lay out the case for that. But the catch is that I want to emphasize it's a hypothesis, and that I don't want anyone to be instructed or to take anything I'm saying as medical advice.
Yeah, I think that, if we go back to why some individuals might not want to have a conversation with you, I think that some of them are of the view that people hear what you say and prematurely adopt a diet and elevate their apoB thinking that they have no risk.
Yeah, and again, you can happily turn this into a clip for the future. I don't want anything that I say, nor would I want anything that I'm doing to become somebody's sole reason for their decision making. As I've said a million times before, I want people to work with their doctor, to work with their family, to understand as best they can what they need to do. Now, all of that said, I will emphasize that I do think that there's points that I bring to bear that I think are important to consider from a scientific examination standpoint. And in the case of apoB containing lipoproteins, virtually all of the data that we have that show an association between apoB and atherosclerosis come from populations that have some version of a cluster that include these confounders. And I think that's very relevant. So I can divide them into two buckets. Bucket number one, you were touching on, which is it's pathological insulin resistance. I'm going to just kind of group it together and call it insulin resistance syndrome, but it generally exhibits what's known as metabolic syndrome, the big five that we're used to hearing: low HDL, high triglycerides, blood pressure, waist to hip ratio. And so in the case of this manifestation, to simplify it, because you'll appreciate this, I'm going to use avatars because you like to do that, right? So let's say we have identical
You've been
twins.
listening to the show, Dave.
Yes,
I'm
I have
impressed.
been. I have been. So we have identical twins. One is Abby, one is Betty, right? And Abby and Betty are living their life, and at age 20, Betty decides to take on a bad dietary lifestyle, starts developing ultimately insulin resistance syndrome in her 40s. She starts gaining weight. She starts developing visceral fat. The two things we can anticipate are likely is her HDL cholesterol goes down and her triglycerides go up compared to her twin. And modestly, her LDL cholesterol increases, but modestly. We also know what's also going on under the hood. Almost certainly her apoB containing lipoproteins are also going up. Now, I've drawn a line to causal directionality. Her developing insulin resistance syndrome resulted in this change in her lipid profile. Now, I think the three of us here would agree that the insulin resistance syndrome is independently causal, at least in part, towards her risk for cardiovascular disease. We agree on that, right? The question then is how much the change in the profile, the lipid profile, particularly the increase in apoB containing lipoproteins, are in addition independently causal towards her atherosclerosis. Now, that's one bucket. Bucket number two is, let's change it. This time, the identical twins are separated by the fact that Betty is born with homozygous familial hypercholesterolemia, HoFH. So she has extraordinarily high levels of LDL cholesterol and apoB containing lipoproteins from birth. She develops atherosclerotic cardiovascular disease at age 3. She has her first MI at age 6. But she does not have the symptoms typical of metabolic syndrome, of insulin resistance. But there is a key difference that I would draw attention to. It's not just that she has less clearance by her hepatocytes, the liver, which is where we're all typically focusing. All her nucleated cells are different, and that includes the immune cells. And that includes macrophages. Macrophages themselves and their capability in metabolizing lipoproteins, I believe, is to be very relevant in this larger story of the development of atherosclerosis. I think that's also something that we see in how the manifestation of disease with those who have homozygous FH turn out. One of your prior podcasts, you referred to something that is near and dear to my heart for discussion on this larger topic, which is cholesterol years, often referred to as milligram years. And there's a great study on 6 children that include CT angiography. And the reason I like it so much is because we rarely get modern science with children who have CT angiograms. And of the 6 children, it's heartbreaking, but this is just the case with HoFH children. 4 of the 6 have not only atherosclerotic cardiovascular disease as detected by the CCTAs, but have it at multiple sites. And this is very commonplace for those who have this disease when they're born with it, is it's in multiple locations and develops at multiple locations. It's not like, say, the runner who might get it in, say, just the LAD, like they have an intense occlusion just in the LAD and not hardly anywhere else throughout the coronary arteries. So this is why all roads lead back to this research. I realize we haven't talked about it yet, but this study on folks like myself, like on Nick Norwitz, like on Adrian Sotomoda, who are on low-carb diets, who see some increase in apoB-containing lipoproteins along with LDL, but outside of these 2 buckets, outside of some form of dysfunction in lipid metabolism.
Let's come back to that in a second. I have a few questions on what you just went through. So my first one is on the genetic data that you were referring to, and you said you believe the macrophages might be implicated. So the change in macrophage function might be explaining some of the heightened risk that we see in individuals who have genetically elevated LDL.
Correct.
My understanding is there's 40, 50 plus different alleles that result in LDL cholesterol being increased. Do we see different macrophage behavior across the board?
Well, I can only speak to this study that I was able to see where they cultured macrophages of specifically HoFH, and they were able to see the expression of LDL receptors. Of course, there's a whole family of LDL receptors. It's not just, of course, the main one that we hear about all the time. So I can't speak as much to other variations of FH. What I can say, though, is that there are genetic diseases that result in increased LDL and apoB and even increased triglycerides, but that aren't actually, the etiology of them is not actually originating with a dysfunction in lipid metabolism. It's a dysfunction elsewhere that's very relevant to the Lipid Energy Model, which is in glycogen stores. So glycogen storage disease 1A, for example, results in a poor ability to synthesize glycogen. And the reason, of course, that's very relevant to us in the case of lean mass hyperresponders is that's kind of simulating in a roundabout way what is at the heart of our hypothesis, which is that lower hepatic glycogen stores can induce this greater amount of lipid circulation. What's interesting about that is glycogen storage disease 1A has this downstream impact, but not due to poor lipid metabolism, but does result in higher levels of LDL cholesterol and apoB, and yet they do not have the associated higher corresponding levels of atherosclerotic cardiovascular disease. That's why there's been a lot of studies where they're trying to figure out exactly why. The Lipid Energy Model might explain why that's the case.
Have you seen that, Bill?
Well, let me go back to a couple of things. Macrophages. Macrophages, in the context of atherosclerotic cardiovascular disease, are scavengers. They have no off button. They will express scavenger receptors in proportion to the things in their environment with which they're trying to clear. If you put more LDL in the environment, you will have more uptake in macrophages. You'll get big macrophage foam cells. And so they basically are the cleanup crew. They are there trying to rid the environment of this. Steps we have not talked about that I believe interact with this idea of macrophages and what's happening have to do with the fact that lipoproteins that are in the blood end up in the wall of the artery. Now, how do they do that? In the past, we thought they just kind of wiggled through the cells that line the blood vessel, the endothelial cells. And so these things have little gap junctions, and they wiggle their way through. What we now believe is that it's a much more active process, transcytosis.
They're going through the cell.
No, they're going through the cell, right? So they're transcytosing through the cell. They're not trying to wiggle in between cells. And that transcytotic process is something that in and of itself is very dynamic. It's very influenced by a variety of things. And so the fact that we have high apoB on one part of the equation and it's getting into the subendothelial space on the other part of the equation requires this transcytosis. And transcytosis can be influenced in a variety of ways. And this is where I believe there's a little bit of synergy taking place between the old injury model and the retention model. The response to injury model back in the 70s was we injure our lining of our endothelium, and that allows it to be more permeable to lipoproteins.
From smoking or high blood pressure.
Right. And another way to just kind of make that a little more relevant now is to say those things affect endothelial function. They can affect transcytosis. They can affect things that do impact the movement of apoB. It may not be because they're altering the gap junction so much as they're actually affecting transcytosis. So we have that part of the conversation that's new.
So we've moved from thinking that these lipoproteins that carry cholesterol are moving between cells in the artery wall to now understanding that they're actually going through the cells.
Correct.
They're being transported from one side of the cell.
Exocytosed, right.
Gotcha.
In other words, it's a very controlled manner, whereas it's not mediated by concentration gradient like it's getting pushed into it in a passive manner. It's actually an active manner.
Which raises a lot of questions as to what's the function of that?
Carry the thread on a little bit before we get there. All right, so LDL particles that are in the subendothelial space don't always stay there. They exocytose. They actually pass back and forth like a waiter in the restaurant. They take your order and they go back to the kitchen. And they get your food and they bring it back to you and they go back to the kitchen, right? So lipoproteins move back and forth across this endothelium much more than people would ever expect. It's the ones that get trapped that are where the story occurs. So retention of lipoproteins in the wall of the artery are the particles that are then subject to additional steps that make them the things that macrophage want to eat. Right, so you first have to get in, then you have to get stuck, and once you've retained the particles, in some cases they're already atherogenic remnants. In other cases, they need to be oxidized or post-translationally modified so they become identified as, and that's a problem. And when macrophages begin to clear the environment of these retained, injurious, atherogenic lipoproteins, the macrophage, once it's ingesting these, becomes an activated foam cell. And they begin to secrete a number of chemicals which increase inflammation. There are chemoattractant substances that bring more monocytes and macrophages into the area, adhesion cell molecules. So the activated foam cell is that guy who starts stirring the pot of inflammation and a variety of processes which result in atherosclerosis. So we've just gently touched on holding your hand, diving down a little bit, not blowing your eardrums out.
I appreciate that.
We're just touching on these additional processes, which are an important part of the story of how I go from my blood number is this, my plaque is or isn't here. There are steps in between that are important that are still being elucidated. Now, having said that, I can still go back to at a macro level, using your avatar. I can go back to that and say, what happens if I don't have this protein that is one of the more recent targets of medical therapy, PCSK9? People may never heard of that. What the heck is a PCSK9? It's a protein that limits how many times the LDL receptor goes up and grabs a particle and comes back in the cell. For people who genetically don't have that protein, they have lifelong low LDLs and an 85 to 90% reduction in atherosclerotic risk independent of anything else.
So they're very good at clearing LDL.
They don't have particles in their blood that are making their way into the wall of the artery. Now, why is that? Because there is a gradient there, and the number of particles that are in the blood are low. And that is a direct attenuation of particle entry. If I have a low number in the blood, there is much less entry into the wall of the artery. That's why LDL lowering, apoB lowering, has several potential benefits. One is you don't continue to transport apoB into the wall of the artery, so you begin to blunt the circus of more and more macrophage foam cell formation. You also, with aggressive LDL lowering, stabilize plaques. We know with a variety of techniques from CTA to optimal tomography, you can get to the point where plaques are regressing in size. So on the one hand, apoB can be shown in a variety of contexts to be directly acting in the formation or not of plaque, lowering apoB, directly stabilizing plaque and decreasing events. But even if you are on a PCSK9 inhibitor and you have a median LDL cholesterol of 26 and you stay that way for years, that's a pretty good LDL lowering. People are still having events. Why? Why would people still have events if we've largely taken apoB off the table?
Is it because they already have enough plaque that can be problematic under the wrong environment?
But that plaque's being stabilized. That plaque is no longer as active. We're not contributing to new plaque. We're stabilizing existing plaque. The plaque that is there is not inflamed and contributing. I would argue it's because there are other parts of the process that direct LDL reduction does not always touch. For example, there's a compound called EPA. EPA is part of fish oil. The active ingredients of fish oil are EPA and DHA. There is a purified form of EPA that was studied in a trial looking at 8,000 individuals with vascular disease or diabetes, all managed to a good LDL level. And the addition of purified EPA versus placebo significantly reduced events and had nothing to do with the apoB level. Had nothing to do. But what did it do? Well, by virtue of its physical chemical properties, it's decreasing inflammation in the wall of the artery. It's decreasing oxidation of lipoproteins, which needs to happen before they're going to take up by macrophages. It decreases foam cell formation. It decreases plaque rupture. It decreases clots on top of plaques. So here's a whole nother mechanism that is additive and beneficial on top of whatever the LDL reduction is doing. And it's been shown in many different series to be helpful on top of aggressive LDL reduction. So I just use that as an example that this is a complex process. There is LDL-related risk, and there's atherosclerotic risk that may not be LDL-related.
And that, what you're talking about there, is that, are we really talking about secondary prevention? So that's once people have been exposed to an elevated level of apoB for decades, maybe they've had one event, and then we're intervening. You're saying if you just get their LDL apoB down to 20 milligrams per deciliter, you're not guaranteeing that that person no longer has events.
You'll markedly reduce their events.
Yeah, you'll markedly reduce their events.
But you cannot say that that is sufficient to ameliorate all of the risk that they have.
Sure. Yeah, I think most people can understand that.
But trying to be fair, right? Yeah. Trying to be fair with the whole apoB story.
Sure.
Because as you know, there are people who look at the data and will come to different conclusions. And one of the things I want to do is let the totality of the data teach me, right? So I think as we're having this conversation, part of it is we get into unique combinations of, well, what does that mean that we need more data to help answer the question?
Yeah, there seems to be quite a bit of sort of binary thinking in this area where it's like, it's just that.
That's actually what I want to push back against, though. That's the main issue, is that it's, with respect to any side that's presenting it as just that simple. And I think that's actually something the three of us agree on. I don't think that there, for example, I think a lot of your colleagues would disagree with you on not treating apoB as the central determinant. As one lipidologist put it, that's a straight line. That apoB is a straight line from how much you have all the way up until your cardiovascular death, which kind of brings it back to kind of the cholesterol years as being a commonality.
Well, I'm of that school of thought. I'm of the school of thought that high apoB for a protracted period of time is problematic unless you have data to indicate to the otherwise.
Okay.
So you're saying, essentially, just to be really clear, the earlier in life you can get it down low to a physiologic level, the better.
Yes.
Got you.
So can I draw some distinctions? I am curious because I'm not actually sure exactly where we both mutually stand on this. I think that there's two questions of enormous interest. The first is apoB containing lipoproteins, are they participants in the process of atherosclerosis? As I regularly state often, I believe that they are. I believe they absolutely are a major component to the process of atherosclerosis. The question for me is how much does that provide information? Getting back to the macrophage story, as you know, there have been, for example, trials that take action against the immune response that can have a benefit towards reduction in cardiovascular disease, but there's usually a trade-off in place. There is, of course, an understandable trade-off if you're impairing the immune response. Those who have PCSK9 loss of function, they do have lower cardiovascular risk, full stop. It gets substantially dropped. But with lifelong super low levels of LDL and apoB, do they live longer? Do they have a benefit in longevity such that they have lower all-cause mortality? If there's no trade-off, that's actually what we should observe, right? Because if there's nothing, say, an increase in some other non-cardiovascular disease, we should actually see that they would live longer than those in their same region and cohort.
So I'm going to put a pin in that one. That's a great question, but that's going to take us down a rabbit hole. And the rabbit hole is going to take us down, and you know the answer to this because I just presented this at your conference. And that is that all-cause mortality is a very special endpoint, and one which is hotly debated as to whether it should or should not be significantly improved by apoB reduction. There are reasons to believe that it should. If it's true that atherosclerosis and cardiovascular disease is the number one cause of death, if apoB is critical to that process, if I lower apoB and I lower cardiovascular events, I should vis-a-vis get an improvement in mortality. That seems logical, unless mortality is driven by something else.
Mm-hmm. So if there's a trade-off and then...
But if mortality is driven by metabolic vulnerability and inflammation, which have nothing to do with apoB, then we're actually setting this up as a straw man to fail. You're asking apoB to solve a problem that it's not causing in the first place. apoB is not the reason that people would die if you're looking at newer data that say it's metabolic vulnerability and inflammation that set people up from death from any cause. And these are data that I presented at Dave's conference where whether it's cardiovascular disease or cancer or chronic kidney disease or heart failure or COPD or fill in the blank, the people who are dying are people who are metabolically vulnerable and have high inflammation.
Right. So this is almost a similar argument to, I guess, some people in the ketogenic camp that say you can't just look at people with high LDL that have poor metabolic health and assume that LDL, their risk of atherosclerosis is the same in someone who has good metabolic health. What you're saying here is in people with genetically low apoB, if we're looking at their total mortality, but we're looking at people who have poor metabolic health, it's not the same as looking at someone who gets apoB down very early in life and doesn't have inflammation or insulin resistance.
Close. I think what you're saying is part of it, but I'm zooming back and saying that mortality is a function of metabolic vulnerability and inflammation irrespective of anything else. That is the setup for increased mortality. Now, what we can say is that there is data that would show that in certain situations, LDL lowering improves mortality, but it's not in all cases in all data sets that have been looked at. And I think that some people look at the expectation of mortality improvement as being a universal response to LDL lowering. If you don't show me better mortality, I'm not going to believe the story of apoB contributing to atherosclerosis and reducing events.
Which incidentally is not my position,
Right.
just to emphasize, this is why I brought up PCSK9 loss of function, because now we're talking both lifelong and an extraordinary shift in exposure. I mean, if you can maintain a 35 milligram per deciliter LDL throughout your life, and you've got a whole bunch of other people along with you that are being looked at, and it's the number one killer. Like, we're not talking about Lou Gehrig's disease or something rare for which we wouldn't expect a signal of change. We're talking about the number one killer in the Western world. If we were to go to Africa, for example, right now, and we could reduce the incidence of death by malaria 80%, 85%, I would expect that the population at large would live longer on average. I don't think that there'd be another disease state that might jump up right away so that they're now dying of cancer just as quickly or something along those lines. And so that, in that sense, when we're talking about lifelong, this is why I like it, is it's a strong signal, especially against PCSK9 loss of function wasn't there in 2015 when I started this. Once those studies became available, I got excited because I was like, this answers both questions really well. The first question is there a strong association between apoB containing lipoproteins and the development of atherosclerosis, right? And certainly I've known many people in the low-carb community who would say the two have nothing to do with each other, right? I point to PCSK9 loss of function as a great example. But conversely, on the other side, I would say, but again, ASCVD is the number one killer. You're not going to find an easy way to convince me if you go to any region, any country, if we were to go back in time 200 years ago with penicillin, that we wouldn't, whatever country we took it to, we wouldn't see a longer lifespan for those people who we got involved. If we could find ways.
That is an acute, you're talking about acute conditions versus chronic though.
But okay, sure. But let's take a pill that cures cancer. Let's say I found a pill that cures cancer. Would you expect in trials that were lifelong, that the population that I could apply this to, that they would actually see a net longevity benefit?
What I would argue is it depends on why they're dying, and this is what you're not looping back to. So I've made the statement that metabolic vulnerability and inflammation are the drivers of death. What I can show you in populations, otherwise healthy individuals, they're healthy. They don't have chronic disease. It is their metabolic vulnerability and inflammation, which is their distinguishing characteristic for death, independent of age, independent. So what I'm suggesting is whether you're young or whether you're old, whether you're healthy or whether you have diabetes, whether you have chronic kidney disease, whether you have cardiovascular disease, whether you have cancer, all of those people share one thing. It is their metabolic vulnerability and inflammation, which significantly distinguishes who lives and who dies.
Actually, I got an idea.
And that is independent. And the reason that's important is because if that is true, then this conversation is connecting two things. A story about ASCVD and apoB and mortality, which is a separate story.
If we did a subset analysis on those who do have PCSK9 loss of function intentionally for metabolic health, would you think that there would be a longevity benefit?
I can tell you what the data show. And the data show that if you have lifelong apoB, you live a long and healthy life. Now, whether you live longer than the general population has to do with what's happening in the general population or what's happening in those people. And this is metabolic vulnerability and inflammation. So I keep going back to this. Think of it in terms of infectious disease. 100 years ago when I was in medical school, when people were doing infectious disease rounds, we have two people, same age, same organism, same site of infection. One lives, one dies. They're both given the same antibiotic. Why did one person live and one person die? We say the host, the person who was the better host, had the better survival. Why? Because an antibiotic can be thought of like a stick. I hand you a stick, you're going to go beat away the bacteria. You have a chance to survive this. But what if you're too weak to wield a stick? What if you're such a frail host, such a vulnerable host, that the antibiotic is not as effective under those conditions as it would be in a more healthy individual or a better host?
Okay, so I just want to make sure I'm understanding everything here, because I think Dave's point about PCSK9 loss of function is interesting. Would I be right in saying that in that context, so that population who has loss of function of PCSK9 gene, who has very low apoB, where in the studies that Dave's talking about, there's no total mortality benefit, they're not living longer. You're of the view that it's not apoB that's killing people in that population. It's poor metabolic health.
I'm saying they're living as long as anybody else. There's no evidence they're dying less or more.
So Dave's point is, shouldn't they be getting extra years added to their life if you're taking away the causal factor to atherosclerosis, which
But you're not taking away the causal factor for their mortality. Their causal factor for the mortality is their metabolic vulnerability and their inflammation. And if that is what is driving their mortality, the fact that they've had a long and wonderful life with decreased ASCVD risk and they're living as long as anybody else is to be expected. They're having a wonderful health span with decreased events, and they're living a long and healthy life. But when the time comes to understand why these people are dying, it is metabolic vulnerability and inflammation, which are the rest of that story.
And just to double click on that, and it could take us down a massive rabbit hole, but what do you think is causing that metabolic vulnerability?
So the multi-marker that I am alluding to that we haven't unpacked is called MVX. And MVX is a multi-marker that we developed some years ago to mirror metabolic health, and then glyca and small HDL particle number, which mirrors inflammation. This multi-marker, consisting of 6 individual elements, is unusually robust. As I said, you can look at MESA, you can look at Cathgen, you can look at any number of data sets, and it is eerily good at segregating actual mortality, independent of age, independent of comorbidity, etc. So the fact that that is there is the point I'm making. Now, why would it be there? What would cause the metabolic vulnerability? That's a whole different conversation. And there are many chronic diseases that have what are called this reverse epidemiology, chronic kidney disease. The people who die aren't the obese people, they're the lean people. The people who die don't have the high cholesterol, they have the low cholesterol. The people who die don't have the high blood pressure, they have the low blood pressure. So what's this reverse epidemiology all about? It's their physiology. They have a physiology which is cachectic. These are cachectic individuals, and as they become cachectic, they are demonstrating lower cholesterol, lower body weight, lower blood pressure. And yet, if you look at certain studies, which are very interesting, and they say, okay, what's the relationship of apoB and mortality? And you sometimes see kind of a U-shaped curve.
Right, and people use that often to say, hey, lowering apoB or LDL is not great for mortality.
What happens if you adjust for malnutrition and metabolic vulnerability?
Cancer.
Guess what happens? It's a straight line. Lower is less mortality, higher is more mortality, and the U-shape goes away if you adjust for metabolic vulnerability.
I have to draw a distinction here. There's again, this is less making the case for the opposite than is making the case for us not knowing as much as I think is the confidence right now. So I think that there's a lot of confidence that we can, through the use of statistical instruments like sensitivity analyses, determine the degree with which there are these other impacts of causality, such that we know what the remainder is. And that is certainly one difference that I may have with the two of you, is that's exactly why I want to do studies like the LMHR study, because I don't share that confidence that sensitivity analyses have determined the degree with which each of those are independently causal towards atherosclerosis, so that we can feel confident we know how much apoB independently contributes. That's the catch.
Do you think low serum cholesterol is problematic or could be problematic?
I think it's possible. Part of the challenge is that we need to have, so I'll make the case for you both, in that I do believe that if you're looking at data sets for which there's, say, 2 or 3 years or less, low LDL can be associated with greater mortality due to there being a common cause of both. That's the reverse causality. Now let's say we're looking at 10 years, 15 years, 20 years. Is there a latent disease state that's reducing the LDL that's not being acted on prognostically by doctors? That's a tougher sell to me, Because now what you're saying is in any population where we see the low LDL and we're seeing the higher all-cause mortality at like a decade or more. So we're censoring out everybody who's died in less than a decade and looking only at those people who've died a decade from now or more. And that's still holding up. Reverse causality should have an expiration. There should be a threshold where it flips, where instead low LDL is going to associate with longer lifespan, if indeed it's only pathogenic, if indeed there is no benefit. I think the steelman position, I think even folks who study familial hypercholesterolemia, the steelman position is they would say, no, there are some benefits, there are some immune benefits to LDL, but that really came more in the days when infection was a bigger concern. And that's why it got conserved to the degree that it did.
And so is that why you think there is that active transcytosis occurring where LDLs move from serum into the arterial wall?
Well, yeah. So, okay. If we're going to
go back to that because
we should go back to that because here's the thing. I'm actually quite obsessed with transcytosis. And since the door got opened, I do want to get into a little bit of the geeky zone on that because from the moment we moved to what is, I'd say, the modern, I like to call it lipid hypothesis 2.0.
We're at about 40 foot of depth.
40 foot
Just make sure we don't just jump down to 100 foot.
Oh, he's close.
Yeah. Well, but this is an exciting moment that a lot of people missed, this big dotted line we crossed, which is Brown and Goldstein and really the last, 4.5 decades has been this passive version of LDL particles, including guests you've had on your show, including conversations we've had as far as this being this concentration gradient in the lumen, driving passively this push towards the subintimal space, going through the endothelium. So the point at which there was just broad acknowledgement in the world of lipidology that, no, we're now pretty sure it is transcytosis. The engineer in me got really excited because that's very testable. It's a very testable hypothesis because that's an active process. And not just a little active. It's not like it can just drop in the surface and manage to get to the other side. You have receptors that have to be transcribed, and you have to have ATP extended. You have to have chaperone proteins. We now know that there are many different routes by which there can be the transcytosis. Of course, there's SRB1, which is probably the most common one. The use of CAV1 for caveolae and creating the vesicles. There's actin, actin-induced folding, which actually is less selective, right? All of these are ways by which there's not just endocytosis, but potentially the transcytosis. Now, why? Is there a designed process in, of all places, endothelial cells? I believe it's absolutely engineering. But more importantly, if the concentration gradient is the driver, and that still is what's being thought of as the primary means by which it's entering the subintimal space, we should actually see that reflected in the endothelial cells themselves. You should be able to go into the endothelial cells and find all the clues I just described. You should be able to see more of the receptors themselves present. You should see more of the chaperone proteins. You should be able to see the vesicles themselves. Now, I know I'm making it sound relatively easy, but you have to do all kinds of staining, and there's a lot of processes that are involved to accomplish that. But that said, you should be able to see those processes being driven with endothelial cells. But important thing to add to this is that, per what Dr. Cromwell said, yes, there's already a lot of transcytosis that happens, quote unquote, naturally. We can get into that later. I think it's part of structural demand. I think there's actually a lot more to the story than is assumed, that they're just going in and out as like just passengers. I think they're actually getting made use of. But importantly, endothelial cells are in a state of inflammation are transcytosing more. That means they have a designed process where they are quite literally expressing more for non-modified LDL particles to transcytose them into the subintimal space. I think that's also a crucially important clue.
So you think that is part of the immune response?
Yes. And I've speculated on this for 5-6 years. I believe endothelial cells are participants in the immune response. And I believe it's part of the larger arc of hemostasis.
Could it not be that some flux of apoB containing lipoproteins into the subintimal space is normal and beneficial at a certain concentration, but then can become detrimental at a higher concentration purely because there's just more of them hanging around and therefore there's more chance of them becoming retained.
That's absolutely possible, but it's also testable, right? So a concentration gradient that's higher in, say, an area for which endothelial cells do not typically develop plaque is something that you could check right now. For example, you could check this post-mortem, right? Actually, this might be something that's more your domain as to what we can actually detect and what we can't. But the bottom line is the clues of greater effort towards transcytosis by endothelial cells is completely testable now. The version of passive filtration was harder to look for. But endothelial cells participating in this process of transcytosis, that's absolutely viewable.
What do you think about that, Bill?
Well, several things. So it is being looked at. It is being tested. It's not something that people have observed and then said, well, I don't know what to do next, because, I mean, this is actively being looked at. I want to finish this, then I want to go back to the question you had about low cholesterol and potentially whether that's problematic or not. I think what we are appreciating is that transcytosis is critical to entry of apoB. And on the one hand, you have to have enough apoB particles to make the transcytotic journey more or less, and that is a gradient-driven process. How effective, efficient, and quick transcytosis occurs is what I hear you speaking to, and that is absolutely correct, that we can modulate transcytosis, and we can modulate it under various conditions. In conditions of endothelial dysfunction, broad statement, it will transcytose differently than a healthy, normal functioning endothelium. That is true as well. And so it's an important nuance because it gets us back to this idea that there are physiologic states which, in addition to your apoB level, are together part of the story. It also is this cumulative exposure over time. The longer that you're having transcytosis and the more macrophage foam cells you're making, the more you're accelerating atherosclerosis. Now, there's a little bit of a black box in the middle of that, and the black box is how long and under what conditions does apoB need to be elevated in order to change the natural history of this process. And that's a little bit of a black box. But one of the questions that I thought was interesting is there a low cholesterol? And if so, is it a problem? We can answer this question differently. There are experiments of nature where people have either low or no LDL. A-beta lipoproteinemia, no apoB-containing lipoproteins, 1 in a million. I have one of these patients. Most lipidologists never have a patient.
And that's 0 milligrams per deciliter serum cholesterol.
Correct.
But their cells are still making cholesterol.
They have 0 apoB-containing lipoproteins.
But their cells throughout the body
Every
are still...
cell with a nucleus makes its own cholesterol, right? But in this case, they are not able to traffic with VLDL and apoB-containing lipoproteins.
So this brings me back to my discussion with Tom Dayspring. If I recall correctly, his view is that cholesterol's role in the lipoproteins, or its main role, was to help create structure, which then allows you to package in the triglycerides. Mm-hmm. They can now flow freely in this lipoprotein, which they otherwise wouldn't be able to dissolve into, and then can be taken to cells and used as an energy substrate.
Well, before that even, you have to have the structure of apoB. So apoB is the structural, it's a scaffolding around which you create a lipoprotein particle. If you don't have the scaffolding, you can't make a VLDL particle, you can't make a lipoprotein, right? So the point is that if you have essentially no apoB, then you are not going to have the ability to traffic fat-soluble vitamins and other critical elements because these things aren't being made. And in that setting, it's a horrible disease. These folks go blind, they have long-track neurologic findings, they die a horrible, miserable early death. So is there an example where you can have very low cholesterol and it be absolutely problematic? Yes, A-beta lipoproteinemia. Well, one step removed from that is hypo-beta lipoproteinemia. I make apoB, just not a lot of it. And they largely escape that demise because they have enough apoB-containing lipoproteins to traffic fat-soluble vitamins,
When you say enough, what average level are we talking about?
So LDL cholesterol, 30, 40, right? So these individuals have hypobeta. Now, their consequence can be, for example, if you have a lot of triglyceride synthesis in the liver, what do you do with that triglyceride? Well, you either export it, you burn it, beta oxidation, or it becomes part of the liver, steatosis. If I need apoB to export it, and I, in the insulin resistant state, for example, am overproducing a lot of triglyceride in my liver and I can't export it, these people become steatotic and they go on to NAFL, NASH, and steatohepatitis, right? So there's a consequence in that setting. But hypobeta patients have very low rates of atherosclerosis because they have very low circulating levels of apoB. So that's all production.
And do they have any issues with hormone production?
No. Because that's done primarily by the cells that are nucleated that make their own cholesterol. Now, that's the production side of the house. Why we're making apoB-containing lipoprotein. Then there's the clearance side of the house, PCSK9 deficiency. Without PCSK9, my LDL receptors work overtime and I clear great. So I have a low level, not because I'm not making, but because I'm clearing tremendously well. Is there a consequence to that? Not that we know of. If we look at clinical trials, and one of the big caveats here is we only know about the amount of time that people were studied in the clinical trial. So we can't extrapolate 20, 30, 40 years. We can't do that. But we can say within the life of the study, if we drop LDL cholesterol to a median of 26 with a statin and a PCSK9 together, both of which are clearance exercises, we haven't found a significant consequence to those people compared to individuals at 50, 70, 100. That could be just because it's a short-term phenomenology. We didn't have 20 or 30 years to watch them. Maybe we would learn something if we watched for a longer period of time. But the point I'm making is that really low cholesterol can be a production question or a clearance question. And our best data that there can be a consequence is when it's not produced, not when it's cleared significantly.
Got you.
It's important for it to get into circulation is basically what it comes down to. And that's why he mentioned a number that's comparable. He said A-beta lipoprotein, or rather hypo-beta lipoproteinemia at, say, 30. We just got done talking about loss of function having 35, right? Mm-hmm. So these are like right next to each other. But in this case, it's not entering circulation. In this case, it's coming out of circulation faster. Mm-hmm. That's the key distinction. Right. Can we return to transcytosis just because I do want to put a pin in. I want to button up the distinction I was drawing that I do think is relevant. If transcytosis is increased at a site of inflammation, it becomes a challenge for us to confirm that a healthy endothelium is in fact accumulating LDL particles via non-inflamed transcytosis. That's part of the challenge. No.
Well, I think we go back to FH as the working example there.
But that's
because that's normal endothelium. It's not starting inflamed.
And don't we have other studies like the PISA study and Cardia where there's people with high LDL, if I recall correctly, but have low other cardiovascular disease risk factors that are developing plaque?
It's my understanding with PISA is that they do adjustments against the existing lipids, such as HDL and triglycerides. If PISA has open data, like if we can do an examination on it, I would be interested. But the challenge is that we're still getting back to the mechanistic aspect of it. If we can see in normal lipid metabolism, people who don't have homozygous FH or who don't have some form of dysfunction in their lipid metabolism, that the increased levels of apoB demonstrate that likewise development of plaque. That's why the lean mass hyperresponder study I think will be advantageous because we'll be able to also see if there's a correlation between LDL levels, especially apoB, and both incidence and progression of plaque.
So the soft pushback I would have on that is that their endothelium is fine. Their physiology is fine.
For homozygous FH?
Sure. They are absolutely fine.
Has that been studied?
Because, well, I'll tell you,
I have a gentle pushback.
Okay, let's let Bill talk.
But okay, go ahead. Sorry.
I will tell you that in FH, what you have is one of a number of defects that results in poor clearance of LDL particles. That is your defect. Period.
It's not the only defect, though. It's also their macrophages. I'll give you the study.
No, I would push back on that. But let me finish, and then
I'll bet you $1. Sorry, go ahead.
Macrophages respond to their environment. Macrophages are sitting there saying, my general role is to consume things that I need to rid my environment of. The more things that are there, the more I adapt to my environment, the more I will express various scavenger receptors, etc. Because my environment has changed, my macrophage is changing in response to my environment. The macrophage is not different in and of itself, absent the apoB, which is present in large quantity, requiring it to change. So you can't say because my apoB is high, which forces my macrophage to then adjust, that an adjusted macrophage is inherently an independent problem, independent of the apoB. That's not the way it works. If the apoB is high and driven into and retained in the arterial wall, the macrophage adjusts and has the characteristics that you talk about, not because it is natively that way, but because it is adapting to its environment and doing its job.
I've got the study on my computer. I will pass off the study. We'll leave it at that if you'd like. But I'll just say, per the in vitro study, there literally is a difference in the expression of receptors. I don't know them off the top of my head. I need to have my computer in front of me to show you. But it was part of what I coupled into the transcytosis talk I did because I was that curious about that component, because it literally is part of the scene of the crime. Macrophages and how they function, I think, is very relevant.
But the macrophages and how they function in this context of genetically elevated apoB, are you saying that there is evidence that they're functioning differently to how macrophages would function? Let's say if someone doesn't have genetically elevated apoB but adopts a diet where their apoB goes up to the exact same level and the macrophages adapt, you're saying that in those two contexts, macrophages are behaving differently?
It's not just that they're behaving differently. They're physically different. The macrophage of somebody who has monogenic homozygous FH, per this in vitro study, for example, they are physically different from, say, the macrophages you or I have. Now, again, I'll reemphasize, this is a hypothesis, and I'm not suggesting that I know for sure that that's exactly what's going on. And I'm not saying that I don't know it's combinatorial. It could be. But are they physically different? I would bet.
Because of the increased apoB, they're different. That's the point I would make. It's because of the increased apoB. It's because of the environment in which they are in. If you did not have homozygous FH and you did not have increased numbers of apoB-containing lipoproteins, and there is not increased movement into the subendothelial space.
So if we were to take macrophages of a lean mass hyperresponder with likewise levels of apoB and culture them, they would look identical to those of those who have monogenic FH.
Well, that's a different argument.
But that's not the same argument. That's a different argument.
Clarify that, Bill, because that seems like where I was trying to go.
What I'm saying is when you have homozygous FH, you are born from birth with extremely high apoB levels. Now we're talking about a child, not an adult, with growing tissues and all the physiologic demands that a newborn has. And under those conditions, from the jump, from the get-go, the macrophage is going to have to be reacting to a very different milieu than someone who, at a later point in their life, has a high apoB or high LDL. I'm just saying that if what I understood you to say is that the macrophage in an FH patient is uniquely different. And I'm saying the difference is because they are reacting to the apoB in their environment. It's not that they are a genetically different monocyte macrophage system. It is a monocyte macrophage system which has been insulted from the time the first breath has been drawn and therefore is reacting as it would under those circumstances. That's the point I was making.
Let's just separate the two. I would agree the circumstances are different, but I would also press that there's physically a difference. That macrophage of somebody with FH is physically different. If you culture the macrophage aside, you'll see differences in how the receptors are expressed. And that's the study. Again, if I had the study from you, I'd show us.
Let me agree with you by saying it backwards. If I take a perturbed macrophage and culture it, it's going to be perturbed. You're telling me that you have a perturbed macrophage. And
But you're saying it's environment only.
I'm saying that if it did not have a high apoB, it would not be as you have described it.
And I'm not disagreeing with the environment being different. I'm just saying physically, its DNA is in fact different.
You're saying that depending on the context that sort of underpins the elevation of apoB, if I'm hearing this correctly, the macrophage is behaving or looking differently.
No. I'm saying I'm not disagreeing with there being an environment that can change a macrophage for sure. An environment can change a macrophage. But I'm also saying its genetics are different. It's, again, I'll either be right or I'll be wrong that a macrophage in somebody who's FH, regardless of environment, is in fact physically different.
But it seems to be an important point because is this why you believe in the context of a lean mass hyper responder that apoB may not carry as much risk?
I'm saying I believe it's possible that why there's greater risk in somebody who has homozygous FH is because there's broken lipid metabolism, potentially in cells like macrophages. That may be very relevant. So if I send you a car from my factory and it comes without an engine, right, and it comes without a passenger door or something like that, and you say, I can't drive this car. I say, but it is a car. You can say, but how you manufactured it is improper, and therefore I can't make use of it to, take my girlfriend to the hospital. I think that's a relevant clue. That's kind of important. And that's kind of my larger point with the macrophage is, again, I'm not asserting that I know for sure that that's what it is, but I do think it's something that you've got to look into, or at least at a minimum, help to eliminate, to be able to look at the independent association of causality.
Define lean mass hyper responder. We said it quite a few times and we kind of have defined it, but let's just be really clear.
Yes. So per the original article in July of 2017 and has since been published in, I think, 9 or 10 papers by this point, it is specifically the combination of 3 markers: an LDL cholesterol of 200 milligrams per deciliter or higher, HDL cholesterol of 80 milligrams per deciliter or higher, and triglycerides of 70 milligrams per deciliter or lower. I was writing about it because at the time in 2017, I saw the emergence of what I was regularly just calling the triad, which is just not cut points, but just the combination of high LDL, high HDL, low triglycerides that seemed to be more common in folks who were particularly metabolically healthy. Like the thing that was surprising to myself and to many others is normally you associate having higher levels of LDL cholesterol being part of poor metabolic health. Whereas the highest levels of LDL cholesterol that we were seeing through the community were people like myself. And it seemed to be, conversely, those people who had better and better metabolic health.
What percentage of a group of people that adopt a ketogenic diet are going to end up as a lean mass hyper responder? They're meeting those 3 criteria of LDL over 200 or higher, HDL 80 or higher, was it?
Yep.
And triglycerides 70 or lower.
Well, it used to be hardly anyone. And the reason I say used to is because for the longest time, those people who would adopt this diet were just in a crisis situation. They were typically folks who were morbidly obese and they were just trying any diet. So they heard of Atkins, would try Atkins. But athletic folks were not choosing to adopt Atkins. They were already lean. They were already metabolically healthy. And as the rise of keto, the ketogenic diet, as it became a lot more popular, that's when there seemed to be a higher and higher proportion of folks like myself, like Nick Norwitz, like Adrian Sotomoda. We saw our LDL cholesterol go up as we found benefit in the ketogenic diet, but then that also brought around this new question. Why weren't there more people like us that were seeing this, sky high LDL?
Your current hypothesis, I think you used the language cautiously optimistic. Is that right?
Yeah, although to be fair, I now almost never use the term because people still take it too liberally.
Yeah, so there's
even when
there's
I throw
kind of,
cautious
there's
on
liberal interpretations of it. What is your definition, or what do you mean when you say cautiously optimistic?
Yeah, so I used to say I was optimistic In the scenario where somebody sees, like me, high LDL cholesterol as a result of metabolic fat adaptation, I know that's a mouthful, but in other words, why the LDL is high may be relevant. As my profile grew, more and more people were starting to just take that and run with it. And so I'd say cautiously optimistic. And then eventually I couldn't even count on the cautious. So I just stopped saying it. I now just regularly say things like, I don't know, work with your doctor, we're getting data.
Okay, but if you were to hypothesize, do you think these people are at increased risk of atherosclerosis and developing plaque compared to someone who is all else equal but has a lower apoB LDL?
Oh, actually, I would hypothesize that if somebody were a lean mass hyperresponder and they took every step possible to lower their LDL and apoB, they would likely have a lower outcome chance of say, dying of cardiovascular disease, right? So in other words, if what I wanted to do was to be less likely to die of cardiovascular disease, I would take steps to lower my LDL and apoB as much as possible. But obviously I'm phrasing it that way on purpose because I don't know if there's not a trade-off, that in fact I'm increasing my chances of cancer or infection or other things that are associated with low LDL. Again, emphasizing that I'm not asserting that that is the case, only that I do believe that apoB containing lipoproteins, and as Dr. Cromwell was going through in this podcast, I do believe that if you take very strong steps to reduce them as much as possible, that particular outcome you will affect.
So you don't think that you can get the kind of best of both worlds here, where you take these people that are lean mass high responders, they're improving their metabolic health, and you say, hey, that's great, let's maintain that metabolic health and also optimize apoB at the same time?
I genuinely don't know. The thing I love about the research we're doing right now is we're at least answering that question at a high magnitude level. It's hard to be able to answer that question at a low magnitude level.
So your sort of core belief here is that you're definitely not discounting the research on apoB and disease. It sounds like you're on board with a lot of that. You're just unsure whether there is a total mortality benefit up for grabs if you lower apoB.
When you say disease, are you saying if you lower apoB, you'll get less disease, period?
Atherosclerosis.
So
cardiovascular disease.
Right. So take, for example, what Dr. Cromwell brought up with A beta lipoproteinemia. I've seen the research for sure. There's nearly no plaque that builds up with A beta lipoproteinemia. They seem to be almost like superhuman in that they don't develop it.
The hypos, hypobeta.
Hypobeta lipoproteinemia. However, they have a whole bunch of other issues that come with it. So there's a trade-off, right? And certainly not quality of life enhancing per se. I think a better example, and certainly one I would like to get the data on, are PCSK9 loss of function, not just with lifespan, which we just talked about at length, but with Healthspan. For example, I would love to see the UK Biobank on those who have PCSK9 loss of function and, for example, hospital visits, right, compared to those otherwise who do not have PCSK9 loss of function. Part of what I said was an idea that I didn't get a chance to expand on earlier when Dr. Cromwell was bringing it up is, literally this idea occurred to me while we were chatting, is I'd love to take, say, the top metabolically healthy quartile of those who have PCSK9 loss of function and then match them with a metabolically healthy of the, again, of the surrounding cohort. Because presumably then we would actually see a signal of health span, right, with the PCSK9 loss of function. Because now we're looking at healthy versus healthy, but as you said, with the benefit of low LDL. That should show us a signal of longevity, not just with Healthspan, but also with, not just with lifespan, but also with Healthspan. Would that be a fair hypothesis?
I think Healthspan is the question that is easier to answer, right? So if you're saying a lifetime of fewer events, heart attack, stroke, then the PCSK9
but
cohort.
not just that, also all events.
That's what I'm calling
Cancer,
Healthspan. So,
dementia.
right.
Yeah, exactly.
And we have, so interestingly, a little backstory, you may know this. The way PCSK9 came to be was they were looking at families that were long-lived and absent of cardiovascular disease. And they happen to have really low LDL. I said, well, isn't that interesting? They're living long, they're healthy, they don't have chronic diseases, they don't have cancer, they're looking really good, they have low LDL. What's up with that? PCSK9 deficiency. So the context in which this was identified was exactly the context you're talking about. These are best of all worlds. These people are looking really good. I'd like to know why they're that way. PCSK9 deficiency came up as the genetic marker that they identified. Now, there could be other things, but that's what they identified. And having identified that, that led to a development program saying, well, would it be the case that we could make this a target of therapy? We could come up with, say, a monoclonal antibody that would mimic a genetic situation where we take it out. And then we would ask, what would happen to these people? Well, in the short term, because these are just short-term studies, there's a significant reduction in plaque, stabilization of existing plaque, significant reduction in events, significant reduction in stroke, without, over the short span, a significant risk signal. So that's kind of the backstory. They were looking at these really very healthy, long-lived individuals without ASCVD and with low LDL and said, what's up with that? PCSK9 deficiency. So, as the story has kind of come to us, as we've identified it, that's where you're talking about extending the data, which would be great. But what we do know currently is that that's what characterized these people when they were first identified.
So, this is what I like about my origin with regard to science, is I like asking these questions before the data are in hand. Could all of us, and this is not at all a trick question, could all of us agree that that idea at least sounds like an interesting one to examine with, like, say, the UK Biobank or Copenhagen? Because I'm going to pursue this data. You and I have had some DM conversations, if you don't mind my mentioning, where I've stated it a priori, right? Where I've said, I would like to find any genetic abnormality that results in 70 milligrams per deciliter lifelong. And I'm going to state this in advance before we get the all-cause mortality data. But if you have some ideas on, for example, what would be a good quality of life marker before I get the data, that's the best way to do it.
And I would add one thing to that as we're kind of a priori laying things out. I want MVX in that as well.
Okay.
Because what I know is that mortality in healthy individuals is a function of MVX with nothing else on the table. So if MVX is significantly segregating mortality risk independent of any chronic disease in otherwise healthy individuals, then that needs to be part of the analysis to ask the question, is the longevity signal, as we might expect it to be, improved by lifelong low apoB? Is there an MVX signal that superimposes on that that's also part of the story? So if they had, so we can make it a 2x2. We have favorable low MVX, and we have high MVX, and we have PCSK9 deficiency. And wouldn't it be interesting if long life was attenuated by high MVX and long life was as expected in the setting of low MVX? That's another hypothesis to kind of put in here because it's a new learning that might help us to better understand the data.
Look for our paper in 1 year. We started it here.
Mm-hmm. Right, get cracking, gents. We can reconvene and unpack it.
I'll concede one critique that I have that I think is a valid one a lot of people in the low-carb community have, is that a lot of these data are first acquired with an expectation in mind, and then analysis is applied. And I myself, I wish that there was more of an effort at determining a study design and exactly what it is we're going to do so that we avoid problems like p-hacking, things along those lines.
Recently, I've been working with friend of the pod, Dr. Will Bolsowitz, on his new brand, 38 Terra, an evidence-based prebiotic supplement to optimize gut health. To facilitate online sales, 38 Terra uses Shopify. The major reason 38 Terra chose Shopify over other e-commerce platforms was because of Shopify's focus on customer conversion. Shopify helps you turn browsers into buyers with the internet's best converting checkout, up to 36% better compared to other leading e-commerce platforms. If you're going to spend time and money on marketing, you want to make sure you are converting the people who visit your site into loyal customers. What I also love about Shopify is how no matter how big you want to grow, Shopify gives you everything you need to take control in-house. The Shopify App Store is home to thousands of customizable apps that can easily plug into your website to help with things like upselling, selling products on social media channels like Instagram and TikTok, and much more. To boost your conversion rate and grow your business, sign up for a $1 per month trial period at shopify.com/proof. That's shopify.com/proof, all in lowercase. Okay, so let's come back to your interest in lean mass hyperresponders and the questions that you have. How do you plan on answering them? Well, what is your hypothesis essentially, and how are you going to test that?
So it's really two questions. There's two questions of enormous interest. The first one is the nerdy one, which is the mechanistic explanation for this triad, particularly for this phenotype that's at the center of the research. That one's quite complex. Been working with a lot of folks, including many that you're going to be interviewing ultimately, but that's really not the one that probably most people are watching as closely or even understand as well. The second one is what everyone's interested in, the question of risk. Are lean mass hyperresponders at an increased risk for cardiovascular disease? Now, this is the thing that I think is great, because we'll be able to get around to something both Dr. Cromwell and I have enormous overlap with, which is that apoB and LDL are certainly very interesting. They're very interesting. Metabolic health is probably one of the most gigantic blind spots you can imagine in healthcare today. Even for as much as it's getting talked about, it's not getting talked about enough. It's not getting focused on enough, right? Okay, but bringing it back to LDL apoB, I think that even a lot of non-low carb physicians, in the scenario of a lean mass hyperresponder who has, let's say, an LDL of even as much as 200, 8 years ago, that would be absolutely outrageous. Today, I'm actually surprised at how many people, clinicians outside of the low-carb community, have gotten surprisingly a little bit more permissive about that if everything else looks great. But then you get to somebody who has an LDL of 400 or 500 or 600. Now we're talking Brown and Goldstein's children who were developing atherosclerosis at an extremely rapid rate. Why would anybody leave their LDL at 500, 600, et cetera, especially when we've already published papers leveraging the Lipid Energy Model showing just a very modest reintroduction of carbs, which we won't get into the mechanisms here, can bring that down to the levels we just now talked about, like 200, which again, still seems outrageous, but to many would still be more permissible than being at the 500, 600, and so forth. Well, some folks have truly diseases like, say, epilepsy, where they really do need to keep their carbs that low. Some that we've interviewed for the documentary we're doing are treating, say, bipolar, need to be that low. We also interviewed a prominent low-carb doctor in the UK who uses it to manage her food addiction, which is quite severe. And so those three examples that I've just mentioned, it's not uncommon for them to come from the perspective that we couldn't know what a difference in the quality of life is for them and what the risks are for the converse. So we need to get this data, not just for those that have even mildly elevated LDL, but those who have it at those levels, to at least see if it's not just an increase of cardiovascular disease, but it's that high magnitude of change. That should come through in the data that we're getting right now, particularly with CT angiography.
Earlier, I think you kind of emphasized that, at least with the genetic data, the PCSK9 loss of function, you're not convinced there's an improvement in mortality. But I think you accept that they have less atherosclerotic cardiovascular disease, right?
Yes. Again, I don't know if there's some version of a trade-off. I just don't know.
Right. So why is it in this context of lean mass hyperresponder, and I might have this wrong, but it kind of follows that your hypothesis would be they'll probably have increased plaque progression, but they're going to have lower risk of some other disease, and their total mortality is not going to be different.
Well, this gets us back to the magnitude question. So the magnitude question is, let's say I were to tell you you have an increased risk of dying of a heart attack at age 95. But if you take steps A through Z, you'll have a reduced risk to where you'll be more likely to die of cardiovascular disease at age 100. Obviously, I'm using hyperbole to illustrate a point that the risk level, relatively speaking, seems to be low, even though I'm talking about a difference of 5 years. But it's because of the time horizon is so different from what we're discussing. And if I throw in there, well, there's a trade-off. The trade-off is if you don't die of cardiovascular disease, you're more likely to die of cancer. And for whatever reason, I have absolute knowledge that that's what the trade-off in risk is.
But how are you going to ascertain that in a very short-term study where you're looking at plaque?
With plaque formation, with CT angiography?
Yeah, how are you going to really ascertain whether there is that trade-off?
That's very difficult to determine. But we can determine if there's rapid plaque progression short-term, to at least determine if there's that pronounced increase in risk. That's why I keep bringing it back to magnitude. See, I'm actually making a key concession here that's very important. For those people who are going to be looking at this research that we're doing right now, and they may want to make a categorical claim, I would already be pushing back on it, that we don't know if what you just said isn't true. That, for example, somebody who exhibits a lean mass hyperresponder phenotype, has an LDL of 200 even, wouldn't be better off having a sweet potato a day and bringing their LDL to, let's say, 130 over 25 years, right? Because the magnitude of change is so small that it'd be difficult to pick up and say the study that we have.
Right? Do you have any thoughts on that, Bill?
Well, I would look at it a little differently, and that is that most lipidologists think of exposure over time, as Dave's saying. And because we encounter people who are high when we get them, we really don't know how long they've been that way. In some cases, people have medical records. A lot of times we don't know, right? So you come to me, and for whatever reason, your LDL is high, and I say, first question I always ask my patients, how long has it been that way? I have no idea. So now we're left with a fill in the blank. Has it been a long time? Has it not been a long time? One way to try to answer that question is non-invasive imaging. And if we see plaque, we assume something is going on that has turned a process on that we would like to turn off. And part of understanding that is what else is going on and LDL-related risk, turning that down. Now, in this case, we have people who were doing fine, apparently. They didn't have high LDL. They are metabolically not unhealthy. They seem to be metabolically healthy, at least to first impression.
But didn't you say earlier, and I'm not trying to catch you out, that you had pre-diabetes?
Correct.
Right. So it wasn't as though you were starting with someone who had perfect metabolic health.
Right.
They adopted the diet. They may have had
in
poor
this case,
or non-optimal metabolic health and then become
right. It's an important distinction because, again, if we're looking at the big picture, I don't know who these folks are prior to their identification as, and I adopted keto and this happened to me. I don't know what their history was to that point. So once they have now had this LDL response, what I would be very concerned about is it being high for a long time. That's my concern because the models of disease that we have say there's a consequence that we expect is likely for people who have high apoB for a long period of time. And especially if you could adjust your macronutrient intake, reintroduce carbohydrates, and bring that down to a more acceptable level, that would seem like a very reasonable thing to consider, especially if you have any evidence of plaque, right? But if you have a zero evidence of plaque, either by CAC score or CTA, you're zero.
Even if someone's younger, like in their 20s or 30s?
Yeah, well, let's say you're zero. Okay, so we've looked and you're zero. And the point I'm trying to get to is if you have a high LDL that is new in the setting of no known disease, what is the time frame for that to assert itself into plaque? I don't know the answer to that. I think if you give them 20 or 30 years, the expectation is it will drive atherosclerosis over some period of probable time. Is that 5 years? Is that 10 years? Is that 2 years? That time window is what
Brings it back to the magnitude question.
right. That brings it back to we need to study these people sequentially to be able to answer that question.
Yeah, like you could tell me, given what I've come to understand is the total plaque score. You could tell me, I know for a fact, Dave, that your LDL concentration does mean something, that it's not an unknown in this hypothetical, but it is a known. You will add 1 total plaque score to your total plaque score over 50 years. I would say, oh, okay, well then that's an easy answer, right? Because I've intentionally created a hyperbole for a 50-year time horizon to add 1 total plaque score. But now let's shift it up. Say, no, in 5 years, you'll add 20 to your total plaque score out of a total score of 45. That's hyperbole in the opposite direction, right? The question that's difficult for us to answer, and has been this entire time, is how do you disentangle these clusters of the issues that we're talking about from the apoB that's embedded within them, right? And for metabolic syndrome, that's very difficult. The catalyst event that we were chatting about earlier, and is still very present to all of us, is the work of Brown and Goldstein with those who have homozygous FH. That is why we're so interested in lean mass hyperresponders at those super high levels, at 400, 500, 600. Are they going to look comparable to those who have homozygous FH? That's what we're gathering data on
In terms
right
of
now.
progression of plaque
Correct.
and events?
Yeah. Yes, both. Correct. They correlate, of course, extremely close. So the presentation and progression of plaque, if apoB is the central driver, should be what we would observe
And
in both lean mass hyperresponders.
Are you interested in looking at that in subjects who have no plaque at the onset of adopting a ketogenic diet, when they sort of shift their phenotype to this lean mass hyperresponder phenotype?
Well, of course, because that's, again, getting back to the children of Brown and Goldstein. There was the study that I mentioned that had the 6 children who had homozygous FH. I did the math on their milligram years, so on the cholesterol years. I don't have it in front of me, but I think I remember this from memory. I think they had 14. I think the latest of the children that had not yet developed plaque, I think it was 1,400 milligram years. And I think the earliest for which they did have plaque was 1,800 milligram years. And the heuristic that I've seen you use as a graphic, as well as many others, and it's a heuristic, so it's not something you have to be held to exactly, is like around 5,000 milligram years. It's kind of like this red line, right? And it's great as an illustration for the amount over time, because the faster upward you're going, right? Presumably the faster you're going to show both the presence of plaque and be at risk for an event. And it becomes cumulative, right? It keeps doubling with each, I think, 1,250 milligram years. Well, those children are getting it much, much earlier than 5,000, which goes to Dr. Cromwell's point, in that it is a different context. But already saying it's a different context is a little bit controversial, because that is a cornerstone of the lipid hypothesis to begin with, that their levels are indicative of what the risk velocity is for cholesterol years. But I already know myself a number of folks who are and have been at those levels, again, for medical reasons, typically because they're trying to treat some other disease. And, while I say anything I say is not medical advice, I will tell you that folks I work with, like, say, Dr. Budoff, Karam Nasir, they would be very much a fan of imaging. So even if you're not in our study, it's not the worst idea if you could at least know how much disease you already have.
Question for you, Bill. Let's say someone in their mid-30s presents to you. They've adopted a ketogenic diet. They have an LDL cholesterol of 600, but otherwise healthy, great insulin sensitivity, metabolic health looks good. They have 0 plaque, no family history of cardiovascular disease, and they don't have elevated LP little a. What are you thinking in that context with regards to the management or attention that you give to LDL cholesterol?
I wouldn't want them to stay there. I would not want them to stay there. They're 30 years old. The longer they stay there, the more cumulative exposure risk they have. So number one is I'm not aware of an advantage of them staying there. I don't think they're benefiting themselves by a 300 cholesterol. So if I could adjust their macros and I could bring their LDL down decidedly, as Nick and Dave and others have shown, you can adjust your macros and attenuate that increase. That would be my first step. And say you may be taking keto for a lot of great reasons. I would wonder if you can continue to get those benefits by making a gentle adjustment in your carbohydrate intake, taking the pressure off that drove you to a 600. Let's get you down to something much more reasonable, see if you're getting the keto benefits you're looking for, and then we can have our next step conversation from there.
And if they push back and said, look, doc, I understand what you're saying, but my symptoms, so they're bipolar, are better than they've ever been before. I'm not changing my diet. Or they've tried that and it didn't work. And I'm not familiar with the bipolar dietary intervention studies that are out there. So I can't off the top of my head, tell you if there are other diets that are equally as beneficial or if it's been studied at all. But this is hypothetical. I push back. I say, look, my N=1 anecdotal experience is important to me. Mm-hmm. I feel significantly better in my relationships with myself and others, mood, quality of life. I'm not going to change the foods I'm eating. Are you recommending medications?
I'm saying that I have no data in hand to suggest that a 600 LDL cholesterol doesn't have a negative consequence down the road. There is no data to show me that sustaining that level of LDL for an extended period of time is anything but risky.
So I would knock that down with some type of a lipid-lowering drug in that context if I was open to it.
I would say that the hard conversation is we have to do one of three things. Number one, we leave you the way you are, and we follow you with some sort of imaging modality and wait for something bad to happen, atherosclerosis, and then attack it once we detect it. So one option is to say, if I ever find that I have disease, I'll revisit this conversation. But until I have disease, I'm not going to revisit this conversation for the reasons that you just said. That's one thing that a patient could do. A second thing a patient could do is they could say, I'm willing to make subtle changes in my diet so long as I don't have loss of benefit in the ways that you just described. And if by changing my diet subtly, by just reintroducing some carbs, knocks me down 200 points of my LDL, it's not perfect, but it's better than it was. I'm still getting the benefit that I'm looking for. And under those conditions, I will wait until I have a plaque and do something. That's a second modification. The third is to say, we don't want to expose you to an LDL of 600 needlessly. And if we have to have the keto diet as is currently practiced for the benefit that you're getting out of it, then I would strongly suggest treating that LDL pharmacologically. If we can't agree on some sort of therapeutic lifestyle change, dietary change, in order to lessen the impact of high LDL over time.
And if I have questions about the safety of statins?
I would look at the Statin Safety Task Force data, which is probably the best repository of worldwide statin data. And the National Lipid Association's done this twice. The good and bad of statins is they've been around for a long time. There are millions of patient years of exposure worldwide. So we have lots and lots of real data to look at frequency. So the challenge here is frequency. I don't doubt that there are people who have had horrific stories on statins. The problem is that with the ability of that message to be amplified, it's hard for the average person to understand how frequently that occurs, right? So if somebody has a terrible statin-associated effect, but the frequency in large data sets is extremely low, that's part of the conversation. Versus, I know somebody who, can you guarantee me that that won't be me? I can't guarantee you that won't be you. I can tell you the frequency of adverse effects is best understood in the context of the large exposure risk that has taken place and how frequently these signals occur. And I think that's a good conversation to have, is what are the frequency of these adverse signals and how do we mitigate them?
What is the frequency?
It depends on what you're talking about in the population. So, give you an example. Back in the day when we started with statins, we had Mevacor, followed by Zocor and Pravachol. Those were our first 3 statins. These are all considered moderate intensity statins. The high intensity are Lipitor and Crestor. So these were moderate intensity statins that were used at moderate dosages. So the number of individuals who were having significant problems like myalgias that were limiting their lifestyle, diabetic signals, etc., were very, very low. Why? Because we were using modest doses of a moderate intensity statin. When we started coming up with lots of adverse event signals, whereas when we used high-intensity, high-dose statin therapy. And a lot of this was driven, number one, by the apparent tolerance of statins as first used, and secondly, by data such as the Miracle trial. Miracle was a study of people with acute coronary syndromes who received 80 milligrams of atorvastatin, and their 30, 60, 90-day morbidity mortality was significantly benefited by being on high-dose statins in the setting of an acute coronary syndrome. This gave apparent cover to the idea, well, maybe we should just use that dose in everybody. Now, if statins are being well tolerated, and this has a good effect in ACS, let's give 80 of atorva in high-risk individuals from the get-go. And by starting with that dose, we precipitated a lot of adverse events. And that was a different way of taking statins than what our first exposure had been when these drugs were coming to market. So I think 2 things can be true at the same time. High-dose, high-intensity statins can absolutely press the adverse event profile, but that doesn't need to be the way we start everybody at the same time. And so for individuals who are statin reluctant, and I like that term, they're very reluctant for good reason, I think we have to first make the case, why would you need a statin in the first place? And remember, the guidelines beginning in 2013, in my opinion, made a good step toward saying it's not for everybody. We should be selective in who we discuss statin therapy with. Do you have ASCVD? Do you have LDL cholesterol 190 or higher on a regular basis? Are you a diabetic 40 to 75 years of age? Do you have high risk as inferred by a validated calculator? These are all candidates for statin therapy, right? That's not everybody. And then the guidelines in 2018 and the ESC guidelines, other guidelines, took it a step further. And that is, well, let's not just look at your categories. Let's look at your risk more broadly. Well, you could use the pooled cohort equation. You could calculate 10-year risk or lifetime risk. But what about all the risk-enhancing factors? Lp(a), chronic kidney disease, metabolic syndrome, women with premature menopause, women with preeclampsia, inflammatory disease, a whole list of risk-enhancing factors. If that's who you are, then the opportunity for LDL lowering takes a little step up. And then the next step is, well, okay, given all this, are you old enough that a non-invasive imaging test would adequately visualize what could be plaque in your vessels? Now, if we look at coronary artery calcium score, it's just calcified lesions. We see not all lesions. If you're a younger person under 40, a 0 means nothing. It doesn't mean you have disease or don't have disease. It can only rule you in. It can't rule you out. But incorporating some type of imaging is the next step the guidelines would say, okay, if you have imaging evidence of disease, we probably ought to talk about the treatment with statins to lower that risk, stabilize plaques. So that discussion, I think, is the better discussion is, am I worried about a statin? I think risk and benefit always have to be balanced.
Right.
And if there's no likelihood of benefit, then any risk is outsized. If there's a high likelihood for benefit, then a small amount of risk. So you have to put that into context.
What percentage of the side effects, and not to downplay them or suggest that they're not real, because they are real. They are real experiences that people go through. Mm-hmm. But what percentages are attributed or could be attributed to the fact that there's a lot of negative stigma, and so people go into taking it thinking they're going to get side effects? Yeah,
the negative bias is real. One data set that speaks to that is Gauss-3. They took people who were self-declared statin intolerant. They randomized them to receive statin versus placebo, and a third of them exposed to statin with no adverse effects. So that is, I believe, an indication that people who are concerned about having adverse effects going in are potentially going to read into experiences a statin consequence, which may or may not be reproducible. The other thing I tell people is a lot of the referrals I get are for statin intolerance, right? So high risk, can't take a statin, go see the lipidologist. Well, things I'd like to know. What's your vitamin D? What's your thyroid status? If you have vitamin D less than 30 and you're hypothyroid that's poorly controlled, these will set you up for statin-associated myalgias, no doubt about it. Have you ever tried Q10? What are other mitigating factors? Have you tried one statin, two statins, several statins? Some statins in individuals are better tolerated than others. Have you ever started with a low-dose statin, atypically dosed, like every third day, and gradually increased to a point where you're on a daily statin? Or did you just start with a high-dose, high-intensity statin, and the first shot over the bow was a bad one? These are all strategies to better understand what could I do if LDL lowering needs to be considered. Another strategy, don't start with a statin.
Do bempedoic acid or something.
Yeah, you can use bempedoic acid. You could use ezetimibe and get to the statin as a second step, right? But bempedoic acid, as you know, works 2 steps up from where a statin works, and it's not active in muscles. Therefore, it's much better tolerated at that level and with outcome-proven benefit in the CLEAR Outcomes study. So some of the factors around the statin conversation with patients are, what their experience has been, what agents they were on, what contributing factors might predispose them to issues. That's one part of it. What non-statin LDL lowering therapy has been proven to have outcome benefit. That's another part of the conversation, right? And then the other part is, and what is the risk that we're trying to mitigate here? Do you have disease? Are you in one of those 4 categories? Do you have a lot of risk-enhancing factors? This is why, with the company I started, Precision Health Reports, we want to put that context in front of people so they have the full field of view from non-invasive imaging, clinical history, risk-enhancing factors, biomarkers, biometrics. What is my story, and how much of this should I consider as I need to do something, and statins may be part of that conversation.
Dave, I appreciate this is slightly out of your wheelhouse or the things that you spend a lot of your time thinking about. And I want to come back to this study or studies that you're involved in. But just quickly, what do you think about the strategy, someone who is a lean mass hyperresponder, lowering their apoB down to, a level that we would say is optimal whilst waiting for data?
I would say, work with your doctor, work with your family, learn what you can. No, I have kind of a stock answer now, because anymore, I want to keep repeating and emphasizing that even when people are saying, Dave, you're somebody I trust, you seem to be smart, you seem to, have some advice that I could probably follow. I say, I've actually worked really hard at linguistically removing as much as I can any hinting of advice, because I'm really trying to be just a researcher, trying to just go get this data and then bring it back. And the more I can do that, the more I can emphasize that what you do about your high LDL, that's really the cart. The horse is what's going on. Is this a problem? Is what I'm most interested in. Now, I will say this, I found an answer that seems to help get me out of the feedback loop, which is that I now defer to Dr. Budov and Dr. Cromwell, who, by the way, have a lot of overlap with Dr. Cromwell with regard to if somebody goes on a ketogenic diet, they see their LDL go high. They are very interested in doing imaging next. If they do imaging and they're satisfied that they're at low risk, then they're interested in letting it be a decision for the patient past that point, whatever it is their next choice is, but to continue monitoring.
But what do they say if the patient says, okay, I have no plaque, but am I at increased risk of laying down plaque? I've only just adopted this diet. I want to kind of know what's going to happen in the next 5-10 years.
I think every doctor that I'm aware of outside of the low carb context at least at those levels, would say, oh, well, if you're just asking me, then I'm not comfortable with it. They would sound like Dr. Cromwell, generally speaking. Now, again, this isn't me giving advice. This is me telling you what people tell me. Obviously, Nick Norwitz and myself, we get asked this a lot because we have untreated higher levels of LDL. But I immediately follow up by saying, we also have CT angiography. He's gotten a CT angiogram once. I've gotten it twice. And I emphasize that this is uncharted territory. That's exactly why we have to do this research.
Do you think some people, I appreciate your position. And I think previously I can put my hand up, I've probably misunderstood you and maybe even misrepresented. So I feel like I'm understanding you more, which is good. That was one of my goals. But do you think some people hear that and think, Dave's an incredibly intelligent guy, and he's happy with it, so I'm just gonna follow suit, and perhaps ahead of the data, just continue to adopt this diet where their apoB is super elevated and take on some risks that they're unaware of? Well,
to that extent, I said what I said right after I mentioned where Dr. Budoff and Dr. Nasir are, in that I meet that first context they described. If I have imaging and I'm low risk, if Nick Norwitz has had imaging, he's at low risk, at least with regard to the plaque that's present currently, right? And we're actively monitoring it. Then to that extent, we kind of meet what it is that their position would be in the first place. I will say that Nick, I believe, and I don't mean to put words in his mouth, but I think he'd be fine with me mentioning this. He said that he might feel differently if he had gotten, a CT angiogram and it turned out that he did have rapidly progressing plaque. Then he might take other steps.
And you're making that choice based on the fact that you don't seem to have had plaque progression. But is there any, I know you're working on a few studies, is there any outcome data at all that looks at this phenotype?
In my opinion, currently, the data that show metabolic health as associates to cardiovascular disease outcome seems to suggest, all else considered, it associates with lower risk at a population level. But the key to emphasize here is population level. So if you're talking to a clinician and they're saying, wait a sec, you as my patient got hung up in a group of people who feel confident that they're safe because a lot of their friends seem to be safe. And by the way, this isn't just in the low carb group. As I'm sure you're aware, there's many people who are on plant-based diets who might, for example, feel that they're at low risk strictly because they're on a plant-based diet, right? And because they have friends who tout highly their cardiovascular health being on a plant-based diet, decide that that's good enough for them and don't pursue further avenues when they uniquely seem to be in an unusual circumstance. And that's why I bring that context to bear.
I think the difference, though, is there's quite a lot of outcome data supporting that dietary pattern for long-term risk reduction.
At a population level.
At a population level.
That's why I'm driving into that. I think you and I agree, I'm certainly betting that Dr. Cromwell agrees. It's all populations until it's a patient. And then when it's a patient, it's their specific context. And then you've got to care a lot more.
But I guess it's a game of probability, even at a population level,
sure.
Right? It's like, it's possible I'm not going to have that because I'm an individual. I'm not going to have the average response that you see in a study. It's possible. But if I'm, playing probability, then I'm likely to have that outcome.
Yeah, and you should care about probability.
More likely to have that outcome, I should say.
You should care about the probability of the studies that you see for the spectrum of data that you have that applies to you in the population that you're in until you can get more distinctive data. That's literally the origin.
Which brings us back to you and your position saying there's a lack of data looking at this phenotype.
Correct. And that's why it's such a challenge to walk this line, because I genuinely want to get through to folks like yourself and say, look, this does not have to fall into this false dichotomy between different camps, if you will. that have these different opinions.
Yeah, I really don't want to be part of a camp.
Yeah.
I've decided that. It's not that fun.
So here's a thought for you. There was a study out of Penn Heart study, and they were interested in trying to tease apart something that you mentioned earlier, and that is the interrelationship between things like insulin resistance and apoB, and is one more important than the other, or are they just part of the same old thing? So what they did was they used coronary artery calcium score as an indication of disease, all right? And if you took a look at HOMA-IR, a validated index of insulin resistance, and apoB, what they found was that if you adjust for all the usual confounders, each one individually was significantly predictive of the presence of disease. Okay, that's good. Now let's start with HOMA-IR and add apoB. Does HOMA-IR still significantly predict? Yes. Let's start with apoB and add HOMA-IR. Does apoB still predict? Yes. All right. Let's do another step. Let's say that I start with apoB and add HOMA-IR. Does apoB significantly add predictive value? Yes. And the vice versa is true. And what they concluded was both significantly independent of each other and after multivariable adjustment were significantly predictive of subclinical disease. That means that if your IR is normal and your apoB is up, that is significantly predictive of disease after multivariate adjustment, and vice versa. If apoB was not up and IR was, it was predictive. So what we're saying is that, again, these things are embedded and overlap. And sometimes I think people kind of stress test the system to say, okay, where does it fall down? Where does this association lose steam? Can it still stand all these additional adjustments? And what I can say is the purpose of doing so is to come up with a sense of the contribution to risk of the punitive biomarker in question. And if apoB, for example, survives all these adjustments, then it is a significant player that should be considered. I think sometimes people stress test this to find a place where the biomarker of interest fails and say, see, I told you it wasn't as bad as you thought it was. It just failed there. I'm not going to believe it anymore. So that's not what we're doing here, but I see people doing that. And I see people kind of playing this game of, I'm going to force it to fail. And a forced failure model, when it fails, is no longer a topic of interest. And so we just have to be aware that some of that is out there. And because people do that, we have to kind of remind them, as we have today, we're not trying to declare a winner or a loser. We're not trying to declare the end-all be-all is this versus that. It is the disease as we understand it, contributed by all of these things, including metabolic health. And if you've got plaque, you've got a disease that's turned on. Do you want to turn it off? I tell my patients, you know what plaque means? Your house is on fire. Now, it may be in your bedroom, but your house is on fire. Are you going to let your house burn down? Or are you going to do something about it? Plaque means your house is on fire, and we should do something about it.
But there is a distinction, which I was kind of mentioning from earlier. Pretend there's a confidence meter, right? The confidence meter is very high. You would, and this isn't rhetorical. You both would feel that existing modeling, existing adjusting, even in the course of when you were soliciting questions for this podcast, I forget who it was who brought up, it might have been Eric Rogers. He was bringing up something, and then you brought up, now wait, was this data looked at, did it have the proper adjustments applied?
I had that here.
Oh, you even had it here. Perfect. Yeah.
It was something that, it was a tweet from Nick, so you can read Nick's tweet.
Okay, perfect, yeah.
That accompanied that.
Right, so this is coming from engineering, and especially with an interest in modeling. We're doing modeling of a different kind. For example, take cell phone coverage, right? So I want to sell you my cell phone service for my business. And I say it's 99.9% coverage. And then you go to your house and it turns out you don't have coverage. You have no signal. And I say, oh, sorry, we were adjusting for weather at the time that we were testing. I guess it turns out that doesn't work. You're going to be upset with me because you got the impression that you would have had the coverage. In the case of adjusting for something we cannot actually yet test independently, so you're making adjustments with things like sensitivity analyses, you are in fact making causal claims with that which you cannot disentangle yet until you can test its predictive power outside of that. That's why we need studies like the lean mass hyperresponder study. We've not been able to independently test specifically high apoB outside of some form of dysfunction or disease. We've needed to get a population like lean mass hyperresponders that otherwise have low cardiovascular risk factors, and seemingly we propose a functional metabolic lipid metabolism specifically. And again, it's not that I'm saying I know for sure that that won't be accounted for. It very well could be, which is what we should be able to see in the data as it emerges.
Yeah, I think the point that I made on this, which I've seen others make, is that, Nick was sharing this and many people have shared it to kind of highlight that the hazard ratio for type 2 diabetes insulin resistance is much greater than LDL cholesterol, right, in this particular study.
But it's not just that. It affects the lipid profile directly. So it affects
So you're saying
your lipids.
Because it affects lipids directly, you shouldn't be adjusting for them.
I'm saying it's difficult to adjust for something that is part of the milieu of what's getting affected by the common cause.
How do you feel about that, Bill?
So this goes back to the study that I just mentioned to you. So two problems with this. Number one, cholesterol is not LDL and LDL is not cholesterol. LDL is a particle that carries cholesterol, and the amount of cholesterol in the particle is highly variable. When you served me this, it had more water. It has less. If I say this glass holds 300 mLs of water, if I have 300 mLs, how many glasses do I have? One if it's full, two if it's half full,
Sure.
so on. So using LDL cholesterol as the metric of a lipoprotein that we may or may not be interested in suffers from an analytic fatal flaw to begin with. So the correct question is, to what degree do atherogenic lipoproteins have something to account? Now, that would be apoB. And then what would we do in an entangled situation? You would have to do these adjusted analyses sequentially in the way that I just did, for example, in the PEN-HEART study. And that is, if insulin resistance and apoB are part of a similar pathophysiology, and I adjust one for the other and vice versa, and put them in the same model. Now, when you put them in the same model, if they're telling you the same story, neither one of them is significantly predictive. Mm-hmm. If I put apoB in the model and it's predictive, and then I add HOMA-IR and it's no longer predictive, I just learned something. Mm-hmm. But if I put it in the model and I add HOMA-IR and it continues to be predictive, and if I start with HOMA-IR and I add apoB and it adds significant predictive value, that tells me while they're related, this is independent. And that's the way that you test the question of independence. Does this independently contribute even after I adjust for these? If you do that type of analysis, you'll come up with a different potential answer than the way this was done.
Right. And so you're of the view that they are independent based on that data. So if you think about the lean mass hyperresponders and the studies that Dave's involved in, you would expect to see plaque progression
over time,
even though they are metabolically healthy.
Now, what I don't know is, because the time question is, if I were not metabolically healthy with a similar apoB versus metabolically healthy with the same apoB, would you expect them to track similarly over time? Or would you expect that there would be an amplification of atherosclerosis by being metabolically unhealthy with a high apoB versus a blunting by being metabolically healthy with apoB? That's what I would expect. And I would expect that if given enough time, you would see, in my opinion, plaque developing in the context of high apoB, but not necessarily at the same rate, with a higher rate in those who are metabolically unhealthy.
When you say over time, you would expect to see plaque progression. What does over time mean?
That's what we need to know. Is it 10 years? Is it 20 years?
Why isn't it right away?
Huh?
Why isn't it right away?
Hold on. So you're saying that there is no plaque progression right away? We haven't really I guess, double-clicked on the studies you're doing.
Oh, no. I'm saying, why would there be a delay in plaque? Maybe here's a better way of asking it. How long does it take LDL to affect plaque?
So it's a great question, and it's a hard question to answer for a variety of reasons. I don't think you can look at pediatric cases of FH and say this is the expectation. So if I have a newborn with HoFH and a LDL cholesterol of 600 and they have a certain rate of plaque progression, say, okay, that's the baseline rate of plaque progression for anybody who has that LDL. That to me is not the same physiology as you or I as adults who have now had a change in our LDL level. So you first, I think,
Can I ask why though? Because
because you're growing as a child, and a child is not a little adult.
Right.
That's what you're assuming, is a child is a little adult, and this little adult acts like an adult does. They just happen to be smaller. And because this little adult has a 600 LDL and they change over this period of time, an adult would be the same thing. So kids in the growing state are a very different creature than an adult.
The only reason I ask, and I'm not trying to catch you out on this, if there is a physiological difference that can be applied back to the lipid hypothesis to explain why it's different for them than it would be for us in a way that can wrap in the lipid hypothesis, I'm interested to know what that would be. Like growth, I definitely think part of me being obsessed with endocytosis is I believe that's part of why it is, for example, that there's lower LDL particle count, particularly in people who are growing rapidly. So I think there's actually greater endocytosis for use for cell growth, for tissue expansion, right? But as far as the lipid hypothesis goes, if greater transcytosis on net at a dose response level is resulting in greater amounts that appear in the subintimal space, every single one is like a lottery ticket that you don't want to win, right? It's kind of like you're playing it over and over again. Do we know what's different about homozygous FH children other than, for example, the things I was bringing up with their physiology?
Several things. First of all, having the same LDL cholesterol level doesn't mean that a lean mass hyperresponder at 500 is a homozygous FH patient. That's not the same. All right, so you can't equate two similar LDL levels and say, oh, this person is just like a homozygous FH, which that's not true. They may have a similar LDL cholesterol level at that point in time, but a homozygous FH person has the inability to clear LDL because of an aberrant LDL receptor axis. It's an LDL receptor axis disorder. And as an LDL receptor axis disorder, that is a different physiology than saying, if the lipid energy model would be the explanation for their high LDL, we're overproducing. We don't have a clearance defect. We have a production issue. That's a different physiology than I can't clear once I make. So again, I would caution you by saying, just because you have a similar LDL cholesterol, you can't conflate one pathophysiology with...
They're different pathways, but they kind of converge at the same point in terms of elevating apoB.
And if you stay that way over years, I would expect there to be plaque. If you have a 600 LDL cholesterol and it's that way for a year and you were to go back down, would I expect plaque in a year? I don't think we have enough data to answer that question.
Is that data looking at like babies that are 2-3 years old that have FH and whether they have plaque progression?
So we can say that without FH, you can look at PDAY study where children killed in car accidents who were autopsied had evidence of atherosclerosis. Right. At age 2, they didn't have FH. They were just a normal 2-year-old. So depending on what you're using as your metric for is there plaque or is there not, we are going to look at tissue under a microscope and say I see plaque because of tissue under a microscope versus I'm going to look at plaque with an imaging technology. Now I need a much greater plaque burden to be detectable by CTA, or even a much greater plaque burden than that if it's a calcified plaque with CAC, right? So this disease process is one that takes a long time to show up in a macro level that we are detecting with some of these non-invasive imaging technologies. So it's a sensitivity issue for detection in part.
How are you planning to kind of navigate that with your study protocols, study designs?
Well, and that's part of it is that I'm wanting to understand as best as I can the critique on the outside. And that's, if you've watched me over the last 8-9 years, I'm constantly planting flags along the way. It's almost like breadcrumbs, if you will, where I'm trying to be sure that we all have in mind what the goalposts that we agree on are. Right now, I actually agree that homozygous FH is a different context. That's kind of the case that I was making from earlier. I think it is a physically different context, and that it won't turn out to be comparable to lean mass hyperresponders. The scenario that I've wanted to drill into, especially now that the data that Dr. Budoff has presented on December 8th with regard to what we've already seen, is that there is a lack of correlation between LDL and corresponding total plaque score. That was quite stunning when I was seeing it, because I was especially interested, particularly for those who had extraordinarily high levels of LDL.
Is that cross-sectional or you're following people?
This was with the matched control. So it is cross-sectional. We do have longitudinal data that's coming next. But the cross-sectional, and I'll reinforce what I've been saying, 100 times. Everyone should expect at a population level that we will see a plaque progression. The question has always been whether or not we'll see a rapid plaque progression, as would be expected if you compared it to homozygous FH. But the goalpost is in a different place now than when it started. Because if you were to go back 8-9 years ago, and I was to tell you, we're going to be looking at a cohort whose average LDL is 272, and whose mean age is 55.5, that's mostly male. And we're going to have baseline 4.7 years at those levels. At 8-9 years ago, everybody would have taken the bet that we would see a rapid progression of plaque, at least at a population level. Now I feel that there's a little bit of a difference. And again, this is not my saying that I believe the goalpost is moved to where people expect there's not going to be any difference, or that this population is safe per se. It's whether or not, again, we're going back to the high magnitude of risk versus suboptimal, which is the case that you were making from earlier. But even so, 272 just 8-9 years ago would sound unfathomable. The fact that our average in our population for this match analysis was 272, that's in the top 10% of the top 1% of the population. It's extremely high levels of LDL.
Explain that study a little more, the cross-sectional study.
Yeah. So, and this is something Dr. Cromwell's gotten a chance to see, and we hadn't had a chance to chat about.
And by the way,
yet.
This is peer-reviewed, but it's not published yet.
Correct. Yeah. So it'll be coming out shortly. But basically, I just described the cohort. So let me take a step back. Here's the lean mass hyperresponder study as it began. We wanted to do a longitudinal study with 100 participants, not quite lean mass hyperresponder cut points, but very close. LDL of 190 or higher, which is, by the way, the guidelines, that at 190 or higher, you should be on the maximally tolerated dose of statin. HDL cholesterol of 60 or higher, triglycerides of 80 or lower. And then a number of other cardiovascular risk factors were identified to be excluded. So pretty much a healthy population, but with the expectation that they're probably going to have sky-high LDL and apoB, which they do. We didn't know for sure how recruitment would go. And then finally, we're getting around to the point where the first scans were completed in February of last year. And thank goodness for Dr. Khram Nasir, who I mentioned earlier. He is the principal investigator for the Miami Heart Study. The Miami Heart Study I didn't know about at the time that we were starting our study. And it's the only other study that actually is looking at asymptomatic participants, and therefore already had a huge pool of people who might have metabolic health that we could do a matched control with, because our group does not have a control group. So a matched control is once we knew that we could be matching against Miami Heart, we found that there were 80 in our pool of 100 with that initial scan data, the initial CT angiography. Sorry, I didn't mention that part. All of the longitudinal data is CT angiograms. So all of them had gotten scanned. All of those 100 scans had been completed in February. From that, we were able to find that there were 80, and by we, I mean Lundquist, because they've got the statistician who does all this, that 80 of the 100 fit within the age range of Miami Heart. And then from that, went to do the match, and the match then determines a group that has averages that match all of the averages as closely as possible to the cohort that we had. Now, unsurprisingly, the one thing that stood out outside of the lipids was BMI, getting back to the Lipid Energy Model, which I didn't go into in depth here, but other people can look it up. We're probably going to not have enough time to hit it. But we believe the higher levels of lipids are related to how lean you are, which we discussed. And so I think our average BMI was 22.5. But in the Miami Heart cohort, even though all of the other things were matched up, the average BMI, I want to say, was 25.8. However, their lipid profile was very comparable in that they also had very high HDL, if memory serves, around 60s, and triglycerides under 100. So probably somebody like yourself. What's your BMI, if you don't mind my asking?
Gosh, put me on the spot here. I think it's actually 24, 25, maybe 25.
Oh, really? 25?
Yeah.
Okay. Anyway, so yeah, but regardless, outside of that, age was matched, 55.5. Ethnicity was perfectly matched. Risk factors were incredibly close. A1C was nearly identical. Blood pressure was nearly identical. C-reactive protein, all were just phenomenally close. Our group had an average LDL, as I mentioned, of 272 milligrams per deciliter. The match had 123 milligrams per deciliter. So again, right down toward the average, right? And interestingly, our group, before they'd gone on a ketogenic diet, had almost identically the same LDL as this group, had 122.
And what was the average in your group?
272. So they had more than twice the LDL of this group. And then here's the kicker. How long had they been at these levels? Well, our eligibility was at least 2 years. The average in this group was 4.7 years, so nearly half a decade. So getting back to the cholesterol years.
How is that verified?
How was it verified that 4.7 years?
Yeah, like each person just voluntarily says how long they've been eating that way, or?
Well, that, and they have to prove to us with their past cholesterol records, their lipid tests. So part of the eligibility for them to get into our study is they had to prove they had a hyper response. So they had to have had an LDL below 160 before, and it had to have changed to at least 190 or higher.
So you rule out that it's genetic.
We also had genetic tests that help confirm that they don't have monogenic FH. We did have one person excused because they did test positive for monogenic FH, but that's 1 out of 100. So they do the match, and the match showed 2 important findings. One is that there was no statistical significance between plaque across multiple metrics. Total plaque score, let me unpack that a little bit. How they do total plaque score is the reader goes through their coronary arteries at 15 predetermined points. And there are 15 points that typically accumulate plaque, such as bifurcations and other bends of shear stress, et cetera. And give it a score between 0 and 3, 0 being no visual plaque of any known quantity, 1 being mild, 2 being medium, 3 being extreme. And with that, with as much as 3 and 15 points of interest, the maximum score could be 45. This was done with both our cohort and with the other cohort, so the total plaque score for our cohort was statistically non-significant and actually trending toward better. There was actually less total plaque in this group versus the other, but I immediately follow up when I say that to still statistically insignificant. So I don't want people to assume for sure that this group was doing better than this group. Just that if this was trending higher, probably many people would say, oh, well, maybe they are going really slow in plaque progression, but probably they're getting closer to breaking out and heading in the other direction. The other metrics are not, I believe, presented by Dr. Budoff, but he did mention them in his talk, so I know it's public information. Other metrics such as total stenosis score, segment involvement score, and I forget what the fourth one is, but there's like 4 different metrics. They were all comparable to the total plaque score. The other major finding is LDL. How much did the LDL associate with the total plaque score? There was no association with either group. So you can actually see the sorted level.
What was the average age?
Average age was 55.5.
What do you think about that, Bill? Is that because that group who adopted the ketogenic diet, they'd done so, what was it, 4 or 5 years?
4.7 years.
I'm trying to think what's the if you look over a lifetime exposure area under the curve, is there a significant difference between the two?
Well, a couple of additional things. So some of the individuals in Miami Heart are on statins, about a third. Mm-hmm. So about a third of those people in Miami Heart are on statin therapy. So that is another factor to consider as to what their numbers look like. In addition to the data that Dave mentioned, 55% of the people in the keto group had a 0 coronary artery calcium score. 45% had a non-zero score. So half of the people, round numbers, 0. Half the people, round numbers, number higher than 0. What I would be interested in longitudinally is for individuals that demonstrated some evidence of plaque versus individuals who demonstrated no evidence of plaque. Would those two groups behave differently with persistent exposure of LDL in the range that you set? I think that could be a very interesting learning. That goes back to what we were talking about before, and that is if we think that it's a combination of factors that affects an individual's trajectory in plaque progression, then if you had nothing to begin with, or you had something to begin with, you might be moving at a different rate. Because what we do know is that atherosclerosis is not a linear process. It doesn't just have a single rate of change over time. The initial rates of change are a while in the coming. And then as you have wall inflammation and other factors that are contributing to the progression of atherosclerosis, it very rapidly picks up steam in some cases. So I think in addition to the data as presented, it will be interesting to watch people over time and see if meaningful subsets behave similarly or different over time.
Was there any thought of removing the people in the Miami study that were on lipid-lowering drugs? Because they were, I'm assuming they were exposed to high LDL earlier in life.
Higher relative LDL, but yeah, a couple of things. One, my preference, just in general, would be to always exclude anybody on cholesterol-lowering medication, although there is a catch in that also creates another potential confounder. So for example, let's say that I was able to make that choice, and I'll explain in a moment that I didn't have the ability to make that choice. If I could have said, hey, only pull from the pool people who did not adopt cholesterol-lowering medication, there is potentially another kind of confounder that introduces, which is non-adherence, right? So one critique that a lot of people will put forward is that we have metabolically healthy
Break that down for me. What do you mean?
So non-adherence as in they're not listening to their doctor's advice.
Because they're not taking a statin. But you have their average LDL in that group, which wasn't that high.
You're talking in Miami Heart group.
Miami, yeah.
Right, but the point Dr. Cromwell is making is that it could be that their average LDL cholesterol was higher pre-statin as to what initiated their doctor giving them advice to take on statin. Now you have this interesting issue, which is that, okay, unfortunately there's now a healthy user bias on those people who would choose to be on statin. If you exclude people who would turn down their doctor's advice anyway, then we might be pulling in people who might otherwise have bad habits. Does that make sense?
Well, I don't know. To me, it sounds like what you're saying is you'd be pulling in people who were perhaps advised to take statins and didn't take them. And then I would expect to see that the average LDL cholesterol of that group now is higher than the 130 that you said.
Yes, but not only that. It might be that by doing that, we could have skewed our Miami Heart population toward people who don't like to follow doctor's advice and therefore might have other bad habits involved. But setting that aside.
What would have been interesting, though, just sort of to cut in, is to remove the people that were taking the lipid-lowering drugs and see what happens to the average LDL cholesterol in the people that remain.
I agree.
Right?
But rightly so, as the funder, I don't get to go into their statistician and be like, now I want it done this way. Okay, now do it this way. Now change this over this way. we understandably have a limited amount of, me being the representative of the Citizen Science Foundation, I have a limited amount of push post hoc, and again, appropriately so. I shouldn't be able to keep playing with the levers after the fact, right? That said, I myself am perfectly comfortable acknowledging all limitations. I wish we all did on all these data, right? So in the case of it's possible that the lipid-lowering therapy started them, that they would have been higher, possibly earlier than that occurred, 100%. I don't want anyone to take the 123 at face value directly. But what I can say with some degree of confidence is this is actually a really good early set of data for what is the general population of what would otherwise be a decent match on metabolic health and what's commonplace for statin use already. That was part of what Dr. Budoff told me when I first saw this. Is I went, hey, why do we have, a third of people using statins? And it's like, have you seen 55-year-olds today? That's actually extremely common. In fact, if anything, it's lower than the average for the general population, probably because so many of them were in good metabolic health.
So Bill, I'm assuming not, but does that being a cross-sectional study, does that in any way change the way that you're treating now, or are you interested by it and, I guess paying attention to other studies that can be done to kind of answer some of those questions?
Well, I think it's good to collect data. It doesn't change the way I'm managing my patients.
Talk to us about the longitudinal study that you're doing.
Well, first of all, I don't actually know. That's being analyzed right now. They have it out to capture with, I'm not sure if I'm able to say who the company is. There's a company that does the analysis, and I'm concerned I may tread into ground that I'm not supposed to discuss. I'll just say that analysis hasn't come back, and I've had no internal preview or anything of the sort. Again, I want to manage everyone's expectations to say what I've already said 100 times before at least, which is expect that there's going to be an increase in plaque, because any group of 55-year-olds, especially mostly male 55-year-olds, even if they're in good metabolic health, are likely going to show at a population level an increase in plaque.
There's no control in that study?
No, because there's no longitudinal data on metabolically healthy people, which I'm quite upset about, Simon. I wish that I wish we just did that more often.
And it's unethical to randomize someone at this point? Like, would any ethics committee approve a randomized controlled trial where you randomize some people to a ketogenic diet, some to a higher carbohydrate diet, look at do a sub-analysis on those that are lean mass hyperresponders?
With full expectation you're going to turn some group into lean mass hyperresponders, or that they already were lean mass hyperresponders?
You're going to turn a certain percentage of them into lean mass hyperresponders.
Like if you're, maybe I'm wrong. You think?
Oh, I don't think they would.
I mean, because that's kind of
that.
Would you say that's the perfect study to kind of set up?
It would be the perfect study, because even a scenario where we RCT, let's say that I've got a lot of pull with the community, and I do have some, right? It's hard right now for me to talk them into an RCT on various lipid-lowering drugs. I mean, after all, that's kind of, but let's just say we even did that. The challenge then is the scrutiny on whether or not the lipid-lowering drug that brought it down enough, for example, and whether or not the community would adhere to it in the first place. That said, there is some discussion on that, and that's a possibility that we might do something like that, but I only want to do it if it can be truly double-blind. I kind of don't want to do an RCT where the population of our cohort is clearly and obviously aware of whether they're in the intervention group or the placebo group. And I've been kind of open about that.
What do you think about that study design?
I think it would be very difficult in the context of a randomized double-blind placebo-controlled trial to try to get to a study design that would test that hypothesis. You're not going to get there. Yeah.
It's tough.
Yeah.
So what's it going to take then? If we can't do that, what's it going to take for clinicians to look at a lean mass hyperresponder and be, I guess, a little more certain in what's happening under the hood? Sorry,
not to cut you off, but this is relevant. You know that we're working on a sister study, though, too. we're setting up a second study that's going to be for this one, which might be relevant to what your answer is, but is important for me to mention here. But yeah, so literally, Dr. Cromwell was just now at a conference that we held to fundraise for the second study, the sister study. And it'll probably be a bit more relaxed criteria. So we may actually get people who are already at moderately higher risk. We haven't determined that criteria yet. And it will have an attached control group. The catch is, I doubt we can do an RCT. But that'll at least provide a bit more data and with a moderately higher risk group in comparison to our current study.
So I guess is what the person's outstanding question is as to what my answer would be. If your outstanding question is, I'm not sure that high LDL is a causal factor for atherosclerosis. I'm not sure that if I'm metabolically healthy, a high LDL is going to be a problem for me. I choose not to want to lower my LDL, and I'm looking for data to suggest that people who have high LDL metabolically healthy do not develop atherosclerosis, and therefore I'm good and I can have my high LDL. I think that's one group of people out there who have a question and they're trying to get that addressed. Another group, I think, are people who are asking the question of, over time, what is the impact of high LDL in the context as Dave described it? And what does it do in individuals who started out with a 0 score or the presence of disease, and how do these two groups behave with longitudinal exposure to high LDL over time? I think that could be an interesting set of data to help people better understand what is the natural history of the disease under these conditions. Because, again, two ways of looking at it. If you have plaque, you have disease. If you have active disease, you either shut it down or you let it go. I'm a clinician with 35 years of experience in this field, and my heavy bias is I want to shut it down before it shuts you down. I am, and this is something Dave and I have talked about many, many times. I carry the burden of not wanting to incite harm. First, do no harm is a critical tenet of clinical medicine. If there is the potential for me to do harm, because every data set I have in my hand says high LDL over time has increased atherosclerotic risk associated with it, then I'm going to use that bias as a major selling point for not staying there. Now, would the data support me? Well, this is why we're collecting data. But in the absence of data to the contrary, persistent exposure to high LDL and high apoB is with consequence. It is not inconsequential.
And just to clarify, the data that you're collecting, at least thus far, is on healthy subjects that do not have a history of cardiovascular disease.
Correct. As in, the eligibility criteria is, I believe, no prior diagnosis of atherosclerotic cardiovascular disease.
I make that point, and it kind of is me agreeing with your other point before, where you were saying it's difficult to look at a study on general public and then sort of generalize that to yourself if you don't reflect the general public. Same sort of thing happening here. I'm imagining if someone has a history of cardiovascular disease, is thinking about adopting a ketogenic diet, the data that you collect in your results are not necessarily generalizable to them.
Which I'm upfront about, which I literally stated at the beginning of the discussion. I'll make this super easy, right? We've already published papers. Literally, our very first paper includes a case series where people titrate in a modest amount of carbohydrates in order to lower their LDL, right? So if you are not metabolically healthy, you have a BMI of, let's say, 26 and above. Let's go even higher. Let's say you have a BMI of 35 and above. We just published a meta-analysis that your lipid levels, by all the criteria Dr. Cromwell would be interested in, improve. All of them. The HDL go up, the triglycerides go down, and importantly, the LDL goes down if your BMI is 35 or higher, probably, given our meta-analysis. This is a meta-analysis of RCTs, 41 RCTs. Now, if it's BMI between 25 and 35, probably it moves marginally, but almost certainly not by a ridiculous amount in one direction or the other, right? If you're below 25 BMI, first of all, you're probably more likely than not metabolically healthy. More likely than not. If you are metabolically healthy and you don't have some illness, something for which you're using a ketogenic diet to treat it, you're just in on the trend, but you're not comfortable with your high LDL. Our first paper published says, hey, here you go. If you want to just bring back some of those carbs, use the principles of the Lipid Energy Model, and you'll see your LDL drop. All right. I think right now I've just covered about 97, 98% of everybody considering a ketogenic diet. We all agree on that, right? The 1 or 2% that's left over, those are the ones that keep me up at night. It's the person who I give, you see how much I give caveats in this podcast. Imagine when I'm talking to somebody who has an LDL of 700 and they're saying, I watch all of your talks, I listen to everything you say. Imagine what I say to that person. I say, this is uncharted territory. Just so you know, there's existing at like 99% of clinicians, probably more, 99.9 would say you need to take steps to lower this. But they're likely telling me something like, I have severe epilepsy. It's so bad. And I find that all of these other medications are not working for me. I want to take my chances. I'm going, okay, we need to get this next study out just as fast as possible.
When you say all these other medications, you mean like with bempedoic acid, statins, lipid-lowering medications? That's what you're talking about?
Yes, although, again, this is where the conversation always turns to where I'm saying, okay, please consider chatting with specialists, please consider. And you have to understand, I do still want to maintain my objectivity and not presenting a push in one direction or the other. The people I work with are more comfortable with nudging. And that's because most of them are clinicians like Dr. Cromwell. So I'll repeat what I say over and over again here to them, which is, look, my job is just to get the data. But for what it's worth, your story definitely makes me more motivated to get it faster. So I'm doing the best that I can.
I think the three of us can probably also agree that, I hope that your study doesn't show increased progression or events, because we need as many dietary options as possible for people. And if there are people are out there genuinely feeling better, they're reducing their symptoms of whether it's bipolar or ulcerative colitis, it would be amazing that this is an option that isn't increasing their risk of cardiovascular disease.
It's just that's a lottery-like bet. I shouldn't go that far, but I'll just put it this way. You randomly grab any 100 people of metabolic health, and I don't even care if they have super low levels of LDL. The age is a big factor. I'm sure you know this. You just get up there into the middle age, and you have a population that already has existing plaque. I'm sorry, if almost half of them do, probably there's going to be at a population level an increase in plaque, even if they are taking lots of steps. Individual level, that's different. An individual can seemingly arrest, but it's hit or miss. Sometimes it's working, sometimes it's not working.
But I hope we can find a middle ground with people. And so I would not want somebody who has cerebral epilepsy to have seizures.
Right.
I wouldn't want that for them. I wouldn't want somebody who has a very symptomatic bipolar to have a consequence that would make that worse. At the same time, I would hope that they would consider slight adjustments in carb intake for the purpose of blunting LDL that might be really, really, really high, and see, is there a way that we can have both at the same time? The benefit of keto without having the high LDL simply by reintroducing carbs. Or, Nick is very facile with this. He has lots of ideas of what you can do to, kind of tweak the system. And
eat
try
some
to
Oreos.
Yeah, well, that's not... I've seen more like PUFAs and things, and things that he has in his toolkit that would, blunt the LDL response. But the idea of I have to stay on this diet with an LDL cholesterol of very high number, whatever the number is, and any reintroduction of carbs will undermine the benefit of my ketogenic diet. I don't know that that's true. I would be sensitive to the idea that just a little bit of reintroduction, let's just give it a consideration.
Yeah, I think that's the pragmatic approach here.
Yeah.
And to be open to that as a possibility.
Just a possibility.
Be open to trying it.
Right.
But
In the absence of data that suggests that, having that level of LDL cholesterol in that certain context is not problematic.
Well, to be fair, again, because they find me, I am in regular discussions with a lot of these folks because I'm like, this is another thing that, just to get a little bit meta, it shouldn't be me only. It's actually very odd to me that we're starting up the sister study and we don't yet have another major study that's getting started yet by another team. I feel like this is such a novel phenotype and really can provide us a lot of useful data around not just the development of atherosclerosis in this context, but on lipid physiology overall. And that's part of the challenge. Part of the challenge is it's slower than I would like, although it's funny. I talk to other researchers and they feel like it's going super fast. But getting back to these folks, like in the case of Nick Norwitz, I knew him earlier on, and I've seen how much this diet's actually helped him specifically, that I get it. He had a very difficult time with, I know that he likes to pitch the exciting aspects of the Your experiment, but he had a very difficult time maintaining that for 2 weeks, given what he has to put up with. That the 6 weeks of the statin, even with the myalgia, was like a cakewalk compared to the Oreos. And there are a lot of folks who found like a new lease on life in keto. So I get it. I get why, from their perspective, it's just non-compromisable.
It's been super interesting. Thank you very much. Dave, is there anything that you want to add here before we close it out, or build on, or something that you wanted to say that we didn't get a chance to cover?
No, I would say it's an exciting time. I'm very thank you for the opportunity to chat with you about this. I really love that I was able to appear with Dr. Cromwell. I'll share this. I've shared it on my own channel before, but it's been a delight to me to see someone of his stature really grok the lipid energy model, because I feel like it's a direction to come, and I'm looking forward to getting tested with stronger experiments ahead. But yeah, I'm also excited for what data we may be talking about in a year from now.
Bill, anything from your end?
I think we still need to think much more broadly about risk than just apoB and LDL, as important as it is. And I'm an apoB card-carrying lipidologist. I'm not giving that up anytime soon. But I do think that as the guidelines have evolved, there's a lot more emphasis on thinking about the individual who has the high LDL. Do you have plaque, non-invasive imaging? What comorbidities do you have? What risk-enhancing factors do you have? And I think that's just a nod to the fact that we need to be thoughtful about who the individual is. We need to have a different conversation with people who have plaque versus no plaque. We have to have a different conversation with somebody who's already had an event, certainly. And as we're doing that, I think we also need data to help us better understand what is the natural history of these individuals, such as in Dave's cohort, that are being followed, because we don't have that data in hand. As we accumulate this data, it helps us have a more informed conversation. It really is. I mean, we've gotten to that point now where our patients deserve an informed conversation, and we should have that with them.
Well, I think my goal's been achieved for the day. I really wanted to better understand Dave's position, and I kind of wanted to facilitate a conversation in a responsible way, have someone who's very esteemed in this area contribute and help unpack these things. So I think we got there. Thank you very much for coming.
Thank you.
Thanks for having us.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.